Good evening, everyone. I'm Namita Mohanty from the Department of English. It gives me immense pleasure to welcome you all to this inaugural ceremony of the 6-day faculty development program on smart health technologies and medtech innovations, organized by the Department of MCA, Trident Academy of Technology, Bhubaneswar, and it's sponsored by AICT under Atal Academy Initiation. We are delighted to have among us eminent dignitaries, respected faculty members, resource persons, and 180 participants from various institutions who have joined us or are going to join us in this 6-day program for the significant academic event. Respected principals, department heads, coordinators of this event, and everyone who have joined us this evening, I extend a warm welcome to you all. And of course, a special note of welcome goes to the eminent speakers for all the sessions for all the 6 days. Before we begin, let us invoke the divine blessings. I request Principal Trident Academy of Technology, Professor Dr. D.N. Patnaik, and Principal PSCT, Dr. Maya Nayak, to light the lamp and mark the beginning of this session and inaugurate the session. I request Dr. Sumati Baral to please join.
Vakratunda Mahakaya Surya Koti Samaprabha Nirvignam Kuru Me Deva Sarvakaryeshu Sarvada Sarvakaryeshu Sarvada Sarvakaryeshu Sarvada.
Thank you, sir. Thank you, madam, for doing the honor. And thank you, everyone, for joining us in this auspicious beginning. This FGP aims to bring together academicians, researchers, and professionals to explore the transformative role of technology in healthcare, covering areas such as artificial intelligence, Internet of Things, data analytics, wearable devices, and other medtech innovations shaping the future of smart health systems. It's a pleasure to have with us our principal, Trident Academy of Technology, Professor Dr. D.N. Patnaik. And Sir holds a bachelor degree in electrical engineering. He has completed his master's in 2006 and subsequently earned his PhD in power system engineering from Jadavpur University in the year 2012. He has an illustrious professional journey spanning over 3 decades, combining 6 years of industrial experience with 26 years of distinguished service in academia. A visionary academic leader, Dr. D.N. Patnaik has held administrative positions for the past 25 years, steering institutions toward growth and excellence through his commitment to quality education and innovation. He has published numerous research papers in the reputed national and international journals and holds several patents reflecting his research prowess. For his outstanding contributions to the field of engineering education and research, Dr. Patnaik has been honored with several prestigious awards under his dynamic leadership. The institution continues to move forward with a strong focus on innovation, sustainability, and academic excellence. I would request, sir, to give his welcome address on this auspicious beginning.
Thank you, madam. Good evening to everyone present here. On behalf of Trident Academy of Technology, it is a great pleasure to welcome you all to the 6-day faculty development program on smart health technologies and mid-tech innovations. It is organized by the Department of MCA and sponsored by AICT Training and Learning Academies, Hotel. As we step into an era when the world is striving toward a more sustainable, inclusive, and technology-driven future, healthcare stands at the forefront of this transformation. The integration of AI, IoT, big data, and robotics is redefining how we perceive wellness, moving from reactive treatment to preventive and data-driven care that benefits both humanity and the environment. This faculty development program aims to empower educators, professionals to harness emerging technologies responsibly for sustainable development. As we explore telemedicine, wearable devices, cybersecurity, and related domains, our focus is on fostering innovation that aligns with ethics, efficiency, and sustainability. True smart health lies in blending technologies with empathy to create healthcare solutions that are compassionate, accessible, and enduring. I'm confident that the discussions, interactions, and shared insights will ignite new ideas, inspire collaboration, and pave the way for a healthier, smarter, and more sustainable tomorrow. Thank you, and I wish a good program for all of us.
Thank you, sir, for your warm welcome address and telling us why this program is so very important. It's a pleasure to have with us Professor Dr. Maya Nayak, Principal, Trident Academy of Creative Technology. Professor Dr. Maya Nayak received her BE degree in Computer Science and Engineering from Bangalore University, Karnataka, India in 1993. She obtained her ME degree in Communication Systems Engineering from UC Ibulla, Odisha in 1997 and earned her PhD in Computer Science and Engineering from BPUT Odisha in 2009. With over 32 years of experience in teaching, research, and academic administration, Dr. Nayak has made significant contributions to the field of computer science education. She has published 39 research papers in national and international journals and conferences and has delivered several invited talks in areas of soft computing and data mining. Her primary research interests include data mining and soft computing. Her passion and commitment to teaching have earned her national recognition, and she was honored with the Best Engineering College Teacher Award twice in 2014 and in 2015 by the Indian Society of Technical Education, ISTE. Under her mentorship, numerous postgraduate and doctoral students have successfully completed their research in computer science and engineering. It's a pleasure to have you with us here, Madam, today, and I would request Madam to please say something on this and give her.
Good evening to all of you. Respected Principal Sir, Coordinator Dr. Sumadhi Baran, Co-Coordinator Mrs. Tripathy, Dr. Namita, all the participants and my esteemed resource persons. It's such a pleasure to connect with all of you virtually today. As educators and innovators, we are witnessing a remarkable transformation in the way we think about healthcare, thanks to smart health technologies and medtech innovations. Let me start with a small incident. It was around 2 a.m. in a Bangalore hospital. A young doctor finishing her 16-hour shift saw an alert on her screen. Patient in bed number 14, possible cardiac arrest in 4 minutes. The readings looks normal, the patient looked normal, but the doctor trusted the system. Within few minutes, the patient collapsed and the team already prepared. Because of that, the patient got saved. Later, she discovered that the alert came not from a person, but from an AI model trained on millions of ICU data points. That night, a machine saved a life by thinking like a doctor. Let me say, today such examples are becoming common. AI tools can detect lung cancer and brain tumors from scans faster than specialists. Wearable watches monitor our heart rhythm, oxygen levels, and stress, and have even alerted users to silent heart attacks. In surgery, robotic systems like Da Vinci robot allow operations with millimeter precision, shortening recovery time. And in rural India, telemedicine platforms powered by AI are enabling villages to consult top doctors without traveling hundreds of kilometers. Across our country, innovators are building affordable, impactable solutions. AI that can detect tuberculosis from chest x-rays, IoT-based maternal health monitors, and mobile apps that translate medical advice into regional languages. Just imagine a small clinic in Odisha connected to experts in AIMS Delhi through an AI-enabled health network. That is not the future, that is happening now. Yet, amid all this innovation, one thing remains priceless: the human touch. AI may read scans, but only a doctor can read emotions. The future of healthcare, isn't it man versus machine? No, it is man with machine. When technology handles the data, the doctor regains time to care. Finally, smart health technologies are not just gadgets or algorithms. They respect, hope, access, and compassion powered by innovation. And as educators, it's our role to prepare students not to fear AI, but to collaborate with it to heal better, faster, and smarter. Thank you so much.
Machine saved a life that day. The narrative says it all about this program. And it's not always man versus the machine. Let's understand it's man with the machine. Thank you so much, madam. Your address was not only informative, it was very, very educative. And I'm sure your address aligns with this program and it gives us such a profound insight into it. Thank you so much, madam. We have with us Dr. Sumati Barar, and she's an assistant professor in the Department of Master in Computer Applications in Trident Academy of Technology, Bhubaneswar. With strong academic and research background in artificial intelligence, machine learning, and healthcare informatics, she has contributed extensively to research in cardiovascular disease prediction. She has more than 20 years of experience in academic as well as in industry. Her dedication to fostering innovation and interdisciplinary learning continues to inspire both students and fellow educators. She is the coordinator of this event, and we also have a co-coordinator, Tripathy madam. And I would request Sumati madam to give a detail about this program. Please, madam.
Thank you very much, ma'am. Respected principal, Dr. Nikhil,
Professor Dr. Nayak, esteemed resource person, faculty colleagues, and dear participants. A very good evening to one and all. I am Dr. Sumati Varal, coordinator of this AICT Atal FTP program on smart health technologies and medtech innovations, organized by the Department of Master in Computer Applications, Trident Academy of Technology. It gives me immense pleasure to welcome you all to the 6-day FTP scheduled from 10 to 15 November 2025. I extend my heartfelt gratitude to the All India Council for Technical Education for providing us with this wonderful opportunity to host such a timely and significant FDP under the Atal Academy initiative. Over the years, we have witnessed how rapidly technology is reshaping healthcare. This FDP aims to provide a comprehensive understanding of these cutting-edge innovations, that is, how AI assists in diagnosis, how IoT enables real-time patient monitoring, how cybersecurity safeguards sensitive health data, and how data-driven decision-making supports preventive care. The objective of this FDP is not only to impart knowledge, but also to ignite curiosity, encourage research collaboration, and nurture entrepreneurial thinking in the medtech domain. Over the next 6 days, participants will have the privilege of interacting with renowned national and international experts who will share their valuable insights on topics such as AI-driven diagnostics, IoT-based health monitoring, medical image analysis, healthcare automation, and wearable technologies. Each session is designed to provide conceptual clarity through case studies, discussions, and interactive learning. This MDP is a platform to learn, share, and innovate. So, I encourage you all to take full advantage of the expert sessions, actively engage in discussions, and translate your learning into impactful research and classroom practices. Before we proceed, I would like to draw your attention to the certificate eligibility criteria, that is minimum 80% attendance and at least 70% score in assessment test is required. Let us together explore how smart technologies can revolutionize healthcare and contribute towards a healthier and more sustainable society. Once again, a very warm welcome to all of you. Wishing everyone a fruitful and enriching learning experience ahead. Thank you. Thank you all.
Thank you so much, madam, for detailing the program. And I'm sure everybody will have a very learning experience over here. That's all from the inauguration ceremony. And I thank Principal, Private Academy of Technology for Dr. Nayak to have come here and inspired us in such huge way. And I would also express my thanks to the principal, Trident Academy of Creative Technology, Professor Dr. Maya Nayak, for being here with us, because the experience doesn't matter how much we prepare, how nicely we prepare, it's the experience that if it is not there to guide us, then the program could go awry. So thank you so much, sir and madam, for being here. And that's all from the inauguration ceremony. We will now move to the session one. Yeah. Thank you so much, sir. Thank you so much, madam. Let's sit on the other side and participate. Thank you so much. So welcome to session one. So we have two sessions today. So the first session, the topic is emerging trends in health technology and medtech innovation. And our esteemed speaker for this session is Mr. Nikhil Ranjan Nayak, GM Corporate IT and Systems, Apollo Hospitals, ENT Limited. Mr. Nikhil Ranjan Nayak has worked as GM Analytics and Strategy, Apollo Hospitals Limited, Hyderabad from 2021 till 2025. Currently on a sabbatical and entrepreneurial consulting journey as Chief Innovative Officer for Fidelcia System Private Limited, a digital transformation leader with over 18 years of experience in healthcare, IT, and operations, delivering measurable outcomes across ERP implementation, healthcare analytics, enterprise data governance, and digital ecosystem development. As the General Manager, Corporate IT and Strategy at Apollo Hospitals, he has spearheaded multi-million dollar projects such as Salesforce, MedMantra ERP, Oracle Hyperion, FCCS, PCMCS, PBCS, and Apollo 24/7, impacting 30 plus hospitals across 6 regions. Adept at strategic planning, business process re-engineering, and clinical with a proven track record in designing and deploying sales and referral engagement platforms, generating over rupees 1,800 million monthly revenue. A certified PMP, CIPPE, CIPM, SCRUN Master, CHA, ITIL B3, and Prince 2 practitioner. He combines cross-functional team leadership, data-driven decision-making, and compliance-oriented governance to align IT with business strategy. Recognized as a thought leader in healthcare digital innovation, he brings unparalleled expertise in integrating clinical systems, cloud platforms, and advanced analytics to drive enterprise-wide transformation. His education includes MTech, Information Technology from AISC, deemed University Rajasthan, Advanced Diploma in Geoinformatics from CDAC Pune, Advanced Diploma in Computing from CDAC Pune, MBA Systems and Marketing from Department of Business Administration, Utkal University, Bhubaneswar. I welcome Sir, and I would request him to take over this session. I hand over the session to you, sir. Thank you.
Good evening to all. I think dignitaries and the students and the industry people as well as the academic fraternity, they can hear me. Good to go.
Yes, sir.
Yeah. If I'm audible, please, wherever I'm not audible, please sound me off. And wherever you want to stop me, you can stop me, and we will continue with the session. This is a privileged opportunity for me to address such a esteemed, faculties, guests, as well as the techno, those who are building the nation with, students coming up for the market condition as well as the academia front. I would thank everybody in the academic forum because I have been in and out of the academic forum. Very special thank to DN Patnaik sir, principal, then Mr. Dr. Maya Nayak, madam, as well as Dr. Sumati Baral for giving this privileged opportunity. Here a small mention, but a very good memory. Dr. P.K. Mahanti, Dean and Principal MBA, he is my direct teacher. So thank you, sir, for making us feel proud because of your knowledge and handholding and during our academic sessions. Okay, sir. I will start with the session. I have got, a lot of healthcare technology, healthcare industry background. So I'll take the session in 2 parts. One part is why, when you say about healthcare, what does it mean and how does it design what all? Because then only you go to the next level of identifying and doing something on the health, how you are, going to implement these technologies. See, the basic fundamental comes from one word, which is, technology doesn't do anything by its own. There are two things. One is a people and a process. If people are there who will adapt, and the process is there which will follow certain kind of identified measures to follow step by step, then it works. And then when the implementation is a peculiar challenge between adoption versus acceptance. I accept everything. I will go to a college, become an engineer, everything, but I don't want to adopt the skills needed or the adoption, the effort and all. So that is where it comes. I'll go straight forward to share my slide, and we will start with the healthcare technology, and I'll give you the brief of what a hospital does. And yeah, team, can you see this one? Is it visible? Hello.
Yes, sir, it is visible.
Yeah. So see, this is the topic has been given here, emerging trends in healthcare technology, medtech innovations. This FDP, so faculties are there. They would be much better than me as well, I assume. And they can ask me questions or post all the questions to, Sumati madam, as well as the coordinators of that. So to say why we are taking the healthcare or talking of healthcare this point of time, always whatever you talk, it is connection with the academics front or the business front. Here if you look back, our academicians are ready, so business front how good it is. So why you go for adapting or accepting or even thinking of healthcare technology? See, the take is basically uh,
Excuse me, sir. Sir, before starting, can you just make your PPT in round mode so that it will be visible more clear?
yeah.
Yes, sir. Yes, sir. Now you can continue, sir. It's fine, sir.
Oh, okay. So this is where I'm coming back from industry versus academia interface. So it was a pleasure. So I'll go back directly. Why we talk about healthcare today? Because the industry needs a lot of there is a lot of demand. What is the volume of demand? When we say the demand is basically 2030 by 30 it will be 30 billion industry. So where is the market? This is the market, and how much India going to cater to that, and how much we can do and that. So basically, medtech sector is going growing rapidly, and the expected is 2030 it will become 30 billion industry. And where the government of India is initiating, like they are giving lot of brief frills and lot of attention to make our people able. That is Ayushman Bharat digital mission is there, make in India, anybody want to start a startup, that is there. Then Nitya is also coming with incubators, and the now university colleges are allowed with that. And the BIRAC is a biotechnology related thing, very specifically biotechnology. If I go back, their digital medicine they are giving the class 6 or class to class 10 projects. It was amazing. Today I think, oh, how to design it. They are giving the thoughts to their to think about it. Then this growth of healthcare entrepreneurship and all these things are there. So today, very surprising healthcare entrepreneurship. If you talk about, no, there are certain agencies who started. If you want to do a clinic, if you want to do a hospital, they are funding it, which was very surprising. Which I explored 15 days back only. So there is no dearth of anybody putting their efforts into make this healthcare domain grow. Secondly, this current landscape is, medtech market is valued by 20 billion by 2024, except this US jolt for H1B and all. So rest others, the market is actually booming. So it is moving to from US to Canada and Europe basically. And the only challenge we get healthcare transformation is basically the US healthcare speaks a different way, where rules, regulations, insurances are there. Indian thing is more of cash driven, and insurance is picking up. So, but everything is digital. Both the things are going. That is where the convergence point. Why we think of Indian healthcare or US healthcare. So there's all government initiatives are already listed down, and there the FDI flows, medtech parks, and PLI schemes. All these things. See, FDI inflows. BlackRock would be one name. Whole half of the world knows. They are going on buying Indian hospitals. They're putting a lot of money into this. Then there are certain auditing firms are coming up. So all this spectrum is going, very big way. So this is the market condition because these are MBA and MCA people. They need to know what is the market condition, why they will do this, why do they adapt and study something. So that is where the backdrop was. So I'll go to the next one. See, this is where we come back to our technology spec. Vision for digital and smart health across India. Fortunately, this was I had a privilege to present it to NABH heads for a group head and Niti Aayog. Some people were there. So the I have to supposed to share them. What is the plan? How people India can adapt digitally? What all can be possible. So we have segregated this. Friends and teachers and all fraternity here. I'm giving a backdrop. How does healthcare starts from a hospital, basically hospital clinics. That is where the backdrop I'm pitching up. Then we'll go to the technology AI. What does it do? And very specifically, I'll talk about a digital twin, which will cover up all these things. It's like a biryani cooked up at the end, where you have got every dishes are separately cooked and then pulled into one plate. This vision is basically connected health ecosystem we have to build. So then only the technology comes, process comes, rules, regulations is and every protocol, whatever you their government, private, and interfaces are coming to picture. If you talk about health information, so health information is catered into this set of things. One is you start with higher education. So you get a certificate educated in certain kind of platforms and all these things. So thinking, you'll get a job and all these things. So that is where you're connected to patients and connected to clinicians. So you have doctors, you have got patients, you have got, your education done. Let's say doctors, nurses, pharmacies, paramedicals and allied healthcare services, all these things. Then it comes to the public health system. I put it for broadly because, in India, it's a private and public. Mostly other countries, they have a public system, which is governed by the government, is that. So then the providers of hospital, nursing center, clinics, their Western world is little divided over it. So these are all connected. So you have got a ID, social security, what is your insurance, where you can go, what all your services you can be taken. You have got the same insurance in India. What is your privilege? Which hospitals are accredited to your insurance and all. So that is where this whole connected healthcare ecosystem comes. Connecting back to the today's agenda is this is where the smart health, connected health, and digital health comes into picture. Digital health, I just can keep it. It is digital. Okay, I can see, send it a WhatsApp and all. But when I say smart health, it helps me to take a decision or it guides me, go back to this place, or you have a condition which you need to attend. So that is where smartness comes into picture. So that is where what are the areas, domains. Basically, I say this is where, domain will come into picture like specialties. You say cardiac, you got ortho, you got, neuro, you got so many others. So this is where we cannot let go any one of it. So that is where, we have life science labs and research organization for pharmacies and then payers, those who are, insurance and other. So this is what gave us the connected health ecosystem from where we'll go back to the technology. Then coming back to the second phase is the mobile health vision. So the penetration of mobile and internet is maximum in India. So in this case, you say, you look at the Indian map, which says creating reach touching to a billion lives. It was basically my old organization's approach of touching billion lives. So whenever you touch these billion lives, they are trying to track them digitally by paper, by giving a ID. We call UHID, Unified Health Identification Number. Okay, UHID. And then it is connected to providing quality healthcare to all Indians. That is where, since we know the UHID, we know the age, we know the gender, we know the description of your kind of medical conditions, not diseases, but medical conditions. So we can create a hub, creating a health hub for delivering the healthcare solutions. So now you see, pharmacy chains are coming. That is one hub. Pharmacy is one hub. You say, diagnostic is one hub. The hospital is one hub. Clinicians is one hub. And you say digital doctors available on the mobile apps is another hub. So you create like a platform where we say very precisely called aggregators. No, you create a platform, everybody comes there, serves there, they get the money through them. So that is where a mobile health actually reaches, and mobile health reach to the maximum. So this is where, this IT regulations comes, healthcare regulations comes, telecom regulations comes, that privacy comes, and all these things are coming. So what are the challenges? Why we are in this space? Definitely we have some challenges and some benefits. The challenges is first is accessibility. Who all had access to the hospitals, dispensaries, pharmacies, and cross-functional doctors, and second opinion or any critical disease related informations. Earlier it was not available. Once internet came, world became shorter. Once mobile came, it is then the world became available in your palm. So that is accessibility was a question. It has different aspects of it. Basically, accessibility not because you don't know, not because it is available. People do not know. You do not know the process. You do not know where to find. Okay. So these are few things. So this digital mission for India was basically to find out, everybody given an Aadhaar card and link it to that. Then affordability, how far we can go and what all is there. So this Atal mission, this Rajiv Gandhi mission, and all things came. Even BSKY in Odisha was there. So all affordability related issues, white, those who will below BPL, they will come. So all these things were few things which has been considered into this aspect of getting to. See, how do we do this? We have to digitalize, we have to accept the technology and use the technology, and use the technology efficiently to get the privilege design for them. If you don't have that kind of a notion, then you design something but it is not usable. So that doesn't make any point. The supply demand gap in healthcare, so that is where lot of hospitals opening. Cancer hospitals are very specifically opening. 30% disease will be cancer into 2030, 35. So everybody you see in Odisha, India, all will be opening up a cancer hospitals. Okay, supply demand. Then the doctors availability, nurses availability. How many engineering college and MBA colleges are prospering now? Very significantly low. But if you say nursing, they are, because the demand is 1:5 ratio. So there is, when you search 5 nurses in a normal ICU bed, you get only 2. So there is a gap of 3, and attrition rate is how much? So in 6 months to 1 year time, they just leave. So based on that, the churning power has to be there. And rural and urban divide, available but not accessible. Hospital is there in Bhubaneswar, but I cannot come from Keonjhar because urban rural divide is there. So I don't have a commuting power to reach there. So what you do, digitally access them. So that is where telemedicine and mobile apps and all video calling options are coming to. Curative versus preventive healthcare systems. See, I will tell you one thing: what is curative, what is preventive, and what is disease. Disease where you have identified what is the condition is telling, you are under medication, under supervision. Preventive is something where you want to take care beforehand you are doing something. Okay, so it's all vaccination is basically preventive healthcare. And you go check up, get your parameters done, sugar, cholesterol, and your kidney related all tests you do. Okay, I'm in a safe hands, or I'm in a borderline, like your sugar is going to be, are you getting to a diabetic or non-diabetic, that boundary line. Curative is basically you got a condition, maybe by birth, maybe over a period of staying, doing and eating and whatever it is, but it is curable. Okay, so you can take precautions. So you follow a preventive method, which is getting this zone to, just in the borderline of some disease where you can come back and say, okay, I'm getting sorted out with all these, preventive methods and all. So this is the basic, wholesome gamut of ecosystem in healthcare domain. If you say today is going to exist, I'll go deep into there. Wherever anybody has any questions, can ask me or text. Second thing is more of designing will come little later. See, since we are talking smart health, so first it has to be digital. And since we are talking about different technologies, then the process and the accreditation has to be there in the place. Because without that we cannot. Because you will go in a left way saying, I'm a left driving car. Somebody will come right driving car. Somebody will say I'll drive backward. Somebody will drive forward. It will not. There should be some process. There should be some rules. There should be some qualifying, indicators. There should be some maximized, standard tools which has to be adopted. Then only you can, since the process is in place, you can do certain kind of things. In this case, NABH actually, NABH is a health level, organization accreditation for all labs, hospitals. Now the digital mission of Prime Minister has got NABH digital certification for hospitals, EMR, electronic medical records, EHR, electronic health records. All this has to be certified. So I broadly, 1, 2, 3, 4, 5. These are the key ingredients to create this digital mission framework ready. If I want, if anybody wants, we can get down into this. So basically, EHR, HIS is your health information system, electronic health record, and electronic medical record. These are the things which has to be there. See, first is ensure the equitable access to digital health solutions. So if I have got a solution, you've got a solution, somebody else has got a solution. So it is to be catering to a particular size of hospital, certain kind of features to be there. Then you say, CMM 5 level, CMM 3 level, CM 1 level, like that. ISO 27000 is the healthcare thing. So you have to follow that protocol and get it done. And you are accredited. This software can be used for EMR. That means it has got these 5 points ready. There is no security breach. There is all clinical records are saved in digital mode, which can be accessible. And, it can be shared with a permission, and the privacy is taken care. Those are certain kind of parameters. Whole of these, these stages we'll talk about. And I'm not reading out all detail. Okay. I will say certification framework is always a issue for everybody because you try to manage ourselves because there is not actual technical skill. Actually, there is no data points. Actually, there are certain things which is not cooked in the right way because the design time already we have not considered those factors. So this certification framework has been enforced with everybody so that we can scale to the next level from dispensary to a clinic to a smaller hospital to a tertiary care hospital. So primary, secondary, tertiary is tertiary care hospital where implants can be done. So like liver implants or secondary where operations can be done. Primary where you come with an accident, they can stabilize and get it done. So which is primary care, secondary, tertiary care is can be identified, and based on that we will go. What is the big challenge in this when digital health framework we talk? Implementation and audit is the key. We accept everything, rules, regulation, I will abide by everything, but we don't do that. We always look for the privilege that has to be given. So this is where the quality is compromised basically, and adoption challenges comes into picture. I'll go to the next one, just detailing the same thing in text format, where the same story is written out here, where I'll say this NABH implementation certification increases the number of NABH accredited hospital using digital font. So if we go into the digital font, what happens is how it has to be designed, what is the protocol, what is the security, all this comes into picture. That is the agenda of this thing. And digital health standards is, people talk in different languages. Systems are designed in different languages. Somebody designed in Java, somebody designed VB, somebody designed in some other language SDK. But there is the devices, where devices they have to interact. There is something called a protocol called HL7, Health Level 7 protocol has to be there. So it has to be HIPAA compliant. So this is where a digital health standards comes into picture, where you have to follow that. These devices and your health HIS is hospital information system, lab information system, and health information. Your HIS when it talks to the lab, she just throws some parameters, some data. This temperature is 105, and his cholesterol is high, blood pressure is this. These are all specific information which comes as a number. So the normal application will not understand what has been the machine level language and what has been the what we say 7 layers. Out of that, presentation layer, whatever we're seeing on the screen, that presentation layer things. So that is where the challenge always is interoperability. So today you see, one insurance, one hospital group is accredited with one set of hospitals, other is not accredited. So you cannot go. Very simple, like you get an insurance which is covered with all group of hospitals, but central government scheme is a CGHS, they say, ECHS. Okay. So that is for defense people. So they can go get treated anywhere. So their set of protocol of for talking to the nomenclature of the clinical names are very different. If you say dialysis, everybody understand. If you say hemodialysis, people will half of the people get phased out saying what is the difference in that? There is nothing. I'm just saying there is a ferrous element, iron element, and that is how it comes. See, certification framework and digital health, all these things are the extension of the previous slide. I'll go to the next page. What is the key architecture, how it is planned, and how do we do, or how we planned it? See, basically, we have got a central repository here. According to accreditation, we got, level of hospitals. Okay. So hospitals, clinics, dispensaries, and each hospital is now connected by ambulance, digital, mobile, laptop, and this thing where the digital framework comes into picture. So this is what has been allowed, this has been told to us, how do you implement, how do you plan? So our plan is like every hospital is getting, they're pulling out their data, like census data. Like COVID time, everybody would have realized, how many COVID patients every day. Which hospital, which district, which state is increasing? What is the percentage increase? What is the percentage of mortality? What is the percentage of younger people below 20 mortality is there? How many got cured who is below 20? How many having critical condition, heart conditions or lungs condition got died? Like this is, so you have to plan individual repository here, then take it to central transaction gateways where, they filter out according to the critical parameter, privacy, and then, according to that certification of all these things, a certification framework is there. These hospitals, clinics, and clinicians will always maintain, disease management. How does it go? Basically, they find out the patient demography repository is there, doctor repository is there, electronic medical records are there. How many are digitally recorded? How many are digital not recorded? So we cannot collate them and say that my percentage and accuracy is right. Okay, so you have to follow that particular, design software, follow the protocol and go ahead with it. You create interfaces of, insurance, telemedicine, pharmacy, which will be, tagged and identified into this. So this was a bigger national level plan, which we have presented some point of time. So which that gives me a dimension to present here as well. So what we do in the clinics or hospital, this framework, we always manage disease management programs, cardiac disease management program, liver disease management program, sugar clinics, then you have hypertension clinic. Now one more disease has come, hypertension post COVID. Then mental health is become a very sophisticated word. Earlier that had any issue unless until you say you have got a depression medicine taken up. Disease surveillance nowadays is very much in. So that is where the insurance segment comes into picture. Privacy and confidential management is more of a technical side of thing where, your information should not be given to anybody. If somebody takes, he should have authority. Data privacy, PDPA rule will be coming into Government of India where it says, if my father, mother has given a consent about my, my all clinical details going for a clinical study or something, post 13, I can deny that. Same thing in, HR payroll system. When I leave this organization, they would have doing some kind of analysis, what critical factor, why this gentleman left. Maybe he was keen on salary, he was keen on innovation, he was keen on, timing, he was keen on, work culture, work environment, physical work environment, all that analysis you can deny them saying, this is a privacy, you should post my absence in the organization, nobody can use this data. So till that level, it is going on nowadays. So this was the digital framework. I'll come back. This is the same thing. I put it in literally on the text format, which I was telling in interoperability standards like HL7, already I said health level 7, which is going. And this GDPR is Generalized Data Protection Rule for Europe, where that is that for data privacy and laws. If you are exporting some data from you are getting from Europe or US, you have to follow that. There should be encryption. There should be 3 levels of encryption. Anonymization is there, encryption is there, and there are other forms of this has to be there so that you don't get their real-time data. And that is where CIPM and CIPPE for Europe. I had done that certification because we were forced to do that in the industry, data privacy for that reason. See, this is only a kind of a pictorial depiction saying where do we transit between one to other. You should have a data point. Then you should have validating engine saying the digital standards you are maintaining. Okay, you start with the you start with the patient data, standard nomenclatures. Then what all you carry in this UHID is Unified Health Identification Number, which is it's a more of a Apollo concept, what we call it a registration number. So then whether duplicate authentication, you go to 6 hospitals of Apollo or somewhere where there is a chain of hospitals, you will find 6 different registration numbers here. But here we have created one thing, one patient, one identification, one period of care. So all your care for 6 hospitals can be linked together to give you one EMR, electronic medical record. Okay, when it becomes more personalized, you say health record for you. So then it carries all the detail of this UHID, diagnosis, allergy, other fields. Going back to the next is validation of engine for national digital standards. If you fall into that standards, like compliance and non-compliance will come into. So validation engine makes it. Then data security and personal data privacy rules are maintained. Then you go build certain agencies for certification. So this is what digital health standards has to be done, because centrally when you do something, it is more of a standard driven, because that is where the process comes into picture. Once process comes into picture, your technology will be adapted. Otherwise, you give a brilliant technology way ahead of time, nobody will follow, nobody will accept, adapt. It goes for a toss. So this is what is there. So this is just a pictorial depiction of how we have designed something which anybody in the technology platform or into the academic platform should think in a very broader prospect, whatever the education is. This is where, we have got a data center created where these are all hospitals, main hospitals, satellite centers and clinics. We say hub and spoke model. Spoke is, where it is there. Hub is the main hospital. So if you say Bhubaneswar is our hub, so nearby all clinics, 5-10 thing is hospitals or dispensaries or smaller hospitals, which will just stabilize and get the higher facility. And so you built up a robust system in the main hospital where every facility, you name a service, it is there. You name a doctor is there. You name a critical situation can be handled, it can be there. So that is what you do. And satellite centers and clinics where you got a critical patient, you stabilize, bring them here. So by the time you bringing it, that is where the smart health comes into picture. We call command centers. So if my data center is here, this is where if I say like Bengal, so this is command center. All information about this patient, his 5 years, 10 years, or this particular accident information is getting it here. So if he has to be operated, flown to somewhere to Hyderabad, Andhra Pradesh, this is where critical doctors are there. All 3-4 doctors can connect and have a conversation, and they can do the surgery. So what is the challenge here, or what is the advantage here when we design this kind of integrated system? We should have a main hospital, satellite centers, clinic, everything here. What we say integration part is to be talking to each other. That is where again coming back to your technology, digital technology, smart technology plays a vital role. How smart you are, that smart you are going to save a person's life. So what are the processes here is basically, if I say, HIS, EMR, this is HIS hospital information system. eDoc application is an electronic document. Doctor, earlier days, we created a thing where, doctor can see somebody's very much urgent reports and he can get back and all. So these are all architecture level thing where you have a wholesome thing which you are going to present and design it. So all this HIS market evaluation and all these things, I will just go over this because a lot of names will come where CCB team, you have a dedicated CCB change control board team, so clinical excellence team, operational decision making team. These teams actually comes into picture when you establish any kind of such kind of big infrastructure technology adoption. We had a team which can say that this technology will work for 3 years. It will not work more than 5 years. Your infra is for 5 years. It needs 10 years infra. Let's say now AI ML has come. Data center when we designed, it was 2007. 2025, it is defunct. It doesn't cater anything, but it caters all our day-to-day reports and this. So we have got, massive data center design. Now you see in India, all other country people are coming, opening up a data center because here the scaling factor is very easy. On other countries, rules, regulations, and that is okay. So here I will come to fostering innovation, scaling expansion. I am not bothered about this. Tier 1, Tier 2, fostering innovation, encourage new technologies. Why? Why not? How? If how? What is the reason? What is the volume of activity needed? And then next level is what is the planning? And if you say plan it, do you have the technology people around training? Then adoption, then accepting and really utilizing for getting some kind of outcome like a pharmacy molecule design, which takes years long. So you should have that kind of infrastructure structure and the foresight to do it. So here encouraging new technologies support the integration of AI, machine learning, blockchain for improving diagnosis, treatment, and data security. So what we do now, we cannot be champion of all this. So we start collaborating startups who are good in doing something. So we plug and play, get them a challenge, get them done very exclusively for us, as well as for a particular technology or a particular domain or a particular problem. Then this health tech brings cutting edge solutions for healthcare facility. So that is where I believe this FDP will help you out, finding out what is your domain, either technology wise, otherwise the problem wise, or the subject matter wise, where do you want to start and do something. That is where that academic and industry interface helps everybody. Okay. Then continuous upgrade. Sometimes we don't have that continuous upgrade because our infra doesn't allow, our finance doesn't, capex, opex, all these things are challenging. So digital health has to be existing. So what you do, you tie up with somebody who is giving you the technology solutions. So we use like co-working spaces. Now cloud space is like that. So you have infrastructure, sublet us, we will do something and we'll come back. See, the last one, the key outcomes management deliverables. So this is what where everybody looks back. I have done so much of education, so much of infra, so much of knowledge, everything. What I'm getting out of it. If you see, if I'll go back to ma'am, I'll go back to somewhere the real time data I'll show, but it's a very classified data. See how this breakup of analytics comes into picture in a marketing condition. The last set of activity I was doing, strategy for 34 hospitals. See, this is guys. Everybody just have a look. So we have thought of increasing our market reach. See, estimated population for catchment area is 177 lakhs, and Ayushman coverage is 116 lakhs, 66%. Then 61 lakhs is pending. Nobody captured this market. Since we had a chain of hospitals, we thought of making it. So we have a way of there's very crude way of calculating, showing to you people, not very automated. But this is how we marketing people go. See, FOS is feet on street status. That FOS is feet on street is our salesman status. So if we add 1.5 more salesperson in this, how much of budget or how we needed, how much number of cases we'll get. See, this is the take. This is the problem that we want to expand. So what is the challenge? If Bilaspur, this all is there. So see, altogether 177 is our catchment area, 177 is there. So FY25 unit IP volume is inpatient volume. So from where, how many have come, we have found out. See, is 19,908. So percentage volume is something. So FY volume 25, unit IP, this is AVIP. AVIP is nothing but our doctors, the rural doctors and any doctors, is they refer to Apollo. So what happens is I don't only market, I get a referral so that I give a incentive to them. What is I recognize them. I give certain kind of financial benefits, and their people coming. That is where we have specifically take care of them. All these things. So out of this normal people coming, and through this effort, it is coming is 12 1288. It's healthcare facilitators. Healthcare facilitators, NGOs are there, clinics are there. There are certain kind of other people who run a show like contact points. So they how much they have contributed. So this is what the first set of information we got. So we have found out, out of this 250 Ayush doctors, then one more is there physiotherapies, Ayush doctors, then homeopathy doctors, and other thing. Those we don't touch them. So this is where we found out. Okay, we can if we follow this doctor universe. Our take was like 1635 doctors were there. Okay, for 177, what's 177 lakh, whatever the patient target catchment area. So we realize current AVP doctors, we have 796 doctors who are referring to us. So 1635 is where we can reach. So 49% approximately is reached. So we can go to the next level of catching those to marketing this our doctors skill sets and what all critical diseases can be addressed. All these things were there. So this is one way analytics. We have retail overview for 26. See, we had FY 25, we had 1696 numbers. 15% growth has to be there. See, FY AOP, when I say, guys, it is annual operating plan. How much you will reach? Okay, annual operating plan was telling 1964, and this is FY 25. So last year they have 1696. Now this is 1964. So at least 300 more cases has to come. So 300 cases comes for a month. 12 into 3. So that is how how it has been calculated. So if you say 100% growth is there, 34, 39, they will come in FY. Additional FOS feet on street. So if they get another, this percent number can be achieved with n number of people to be hired. So your revenue in crore was 1791. It has gone to 2329 crores. It will come to 37.82 crores. So that is one of the planning where we are using a definitive analytics to find out patients. Then according to productivity also we'll say 0606 and this feet on street. So first FY 25 was 6. Next FY 26 AOP plan was 6. If you make it AOP plan wise additional 11 numbers, so it will reach 31% of productivity. At present access and conversion ratio is reduced. 24 to 27 is just 3%. So AVIP doctors is our doctors whom we connect them to get the referral patients. HCF healthcare facilitators, clinics, nursing homes, normal practitioners, doctors, and all these things are there. See, this is what I will not describe. This is what I will tell you. Our doctor coverage is this thing. If we cover a doctor, definitely 1, 2, 3 cases will come. So this where it is 1555 is there. Doctor universe is 1755. So still we are running short of nearly 200 less doctors we are not able to reach. And this says conversion ratio where population is 177 lakhs. So this is how we do a bit of homework every time in the marketing and put a strategy. In this strategy, you will find out, what all resource optimization is to be there. Expand coverage within neighborhood market. 10 kilometers radius, how many doctors? Improve active doctor base additional peripheral feeders. Okay, so you call for meetings, you call for seminars, you call for, certain kind of camps. So all these things will be there. So potential A plus or A category is there is a category how many doc patients they assume. So market expansion, we think, Odisha, these 90 doctors are coming from, different doctors we catch and say this part of Odisha is supplying this number of cases. This is kind of cases, this critical kind of cases. And what is the mortality ratio, what is the health index and all. So that is where whether we'll expand to that or not. Let's say, we don't deal with eye patients. Apollo is known for health. Apollo is known for heart cases, neuro cases, and this. So we don't take care of it. So if we today we open up that thing, where all we should go? What is the expansion of this? Why I will open up a eye clinic or open up a eye camp? The basic reason, if you guys know, from your eye, there is this AI has built up something with an urban clinic in Pondicherry where they look at your retina. From there, they can find out your health condition. If we get that tool, we'll try to find out in the village or urban, semi-urban, how many we just give a test and we come back saying, out of that it seems coming 5 years or 2 years, at least 40% will have heart cases, cardiac cases. Should we go back and try to pitch them, try to convince, try to give initiatives to cardiac checks and all? Then we say, see, your condition is this. So this kind of planning is usually goes from the analytics part of. And then driving efficiency is this Congo is a name, cancer, orthopedic, neuro, gyno, and another one is there. So these are the specific areas where we just focus on that. These are certain details of things. See, FY26, yeah, cardiac, ortho, neuro, gastro, oncology. So this Congo part only we focus on. How many cardiac camps we will do? 14. Ortho camps will do 10. Like this, it will come out. And how many cases where we will go and do? CME is our continuous, program of educating people. RTM is a relationship, team meetings. I'll go with my senior, talk to a doctor, talk to that. Why don't you refer us? This and corporate visits is already everybody know. Other city camps will create a camp, health awareness camp, and digital videos will show a critical case a doctor done an operation, or will show 5-10 cases where it is a critical disease that they will come. Okay, newspaper arts and so this is kind of a analytics part where we have done for certain kind of marketing area. So is it making some sense? So I was here, from here I have gone to the competitive awareness and all these things, break up this. So section B is the thing which people may be trying to link it up. I will show a small video at the end saying, what is the thing. So this is where I will say this is a broader picture of where what all in a hospital goes or a clinical forum it goes. This gives an idea of whole lot of end-to-end clinical domain information at what level what is there, what level what is there. So data aggregation and consolidation is our typical needed, because if you don't have data points, that to really curated data points, nothing can come out in technology. You may be running a car, but it is not efficient. It is not making you reach in the destination the time frame needed. The mileage it has to go give, it is not giving. The facility that AC is not working. So like that, if your data points are not correct, accurate, you have to get rid of all noises. Statistical people, they can understand that much better. So that is where it is. So we start with, we will come to the left, consultation, stakeholders, First, we get patients, then medical staff, their information is to their administrations, what all is done, what point of time this has come, what point of time it is processed, what point of time it has gone to the OT, what point of time it has come out of OT, what point of time the pharmacy has supplied the drugs, what point of time the nurse has injected the injection, which is a critical, how frequent, what all. Those kind of all these things are there. And medical students is, DNB doctors nowadays is a part of medical students. They do their internship there and for 2 3 years this, so this all data has to be there, so they should have application access, they should have few knowledge, and portals are there to track it. So health providers and government schemes, so public health channel is there, this is from there the hospitals are connected to data center, then whole hospital related, every we have a chain of hospitals, 84 hospitals. So we have a always have what kind of hospital connected to what data center. So I mean 6 instances, so southern region, central region, northern region, eastern region. So that is how it comes. So each part is there. Then every hospital should have a blood bank and emergency services. So many times people do not have a blood bank in their hospital. They rely on the other outside providers which are linked to them, and they do it. Like similarly, like emergency services, these ambulances are like that. It is mostly a outsourced service. So in those cases, security is also a outsourced service. So those kind of things we have to put together, saying a framework where our MIs or dashboard is coming, executive dashboard, what is profit, what is loss, what all, what percentage this growth sector is showing up. So this is the wholesome framework where you say, my MIS and dashboard is loaded, so your data is approximately very much fine, and say it is whatever the volume you need, it is there, whatever the clarity you need, that is there, the data points is there. So this is how it is going, uh, this is where the surveillance comes into picture, budget and actuals incomes. And nowadays it is, now you take it out what madam was giving example, that SMS pushing, one SMS has come to a doctor at midnight where it got that there is a tentative heart attack or something. That is what we call it a war room. We have got like TV surveillances, CCTV surveillances in many places. Let's say you are in Bhubaneswar, there is a center in Cuttack, there is a center in Dhankanal, there is a center in this. These physical, pharmacies, doctors are sitting there watching, shift-wise watching all the vital parameters of the ICU patients. So those are war rooms, not in the hospital. They will monitor the critical factor which is fluctuating. So immediately they can talk to the doctor saying, this is what. And that is where the patient case is already accessible to them. They can just refer back their case and they will suggest this is what has to be done. Immediately take him for a MRI, CT, or go for cardiac check, and you see do the test, ECG, and all these things. This is the extension of what we have been doing it. So nothing to do, create your capacity building by training, then awareness and stakeholder engagement. So camps, RTMs, all this, monitor and evaluation. So you when you've done the camp, how successful it is, how many cases has come. At the same time, you see performance matrices, how many doctors has gone, contributed to that. All these things are there. And basically interoperability of data and integration is the key factor for us for going to the next level. Yes, guys, I'm on track, or it is needed. Some more time is. We are running short of our time. Hello. See, basically, what I want to say, this is the staggered thing which comes skill upgradation to capacity building to technology dissemination. What we have to throw as a technology, what we have to adapt, what we have to go ahead is all these things are there. At a point of time, global benchmark and quality comes into picture. Once this global benchmark is coming, you have to follow that, because healthcare is always driven by what is running, what is the latest in the market. In that segment, when say technology, innovation, R&D, here we step into the world, what is the smart health, digital health, AI, ML, IoT. AIoT is, artificial intelligence, IoT, Internet of Things. Then IIoT is there, industrial IoT is there, biomarkers are there, digital twin is one more new concept. So basically, I will focus on digital twin for today because which is very very new. If you people know, that is nothing like it. But this is what will cover up AI, ML, IoT, biosensors, and telemedicine. Your virtual machines and VR and all. Okay, so all these things are combined together will create a digital twin. So basically, when I talk about digital twin, what does it mean? If I am a person, I will create a digital twin of myself. So all my parameters, all my clinical parameters, all my physical parameters, my heart, my kidney, my liver, everything is clinically, digitally available somewhere. So if they want to do, like your you creating a duplicate or not a duplicate replica of my heart, they know digitally then what is the heart rate, what is the blood group, what is the artery size, what is the artery wherever the block is. All these things they will have it. So they can simulate a condition saying what condition will make me collapse, what condition will make me revive, what condition will create a situation where I may go fizzy and not very controlling myself on all these things. See, this is where the latest emerging technology in healthcare is the key factor which I'm going to tell. One is artificial intelligence part of it. Then integrated data and predictive analysis. This predictive analysis or integrated data part, I will just that strategy part I've just shown. So need not worry too much, but I'll give one two insights into that. Then nanomedicines are, this now this is a budding area where you can find out internal organs, your inside the tummy and all these things, and this bacterial infection cure and all these things are getting augmented and virtual reality and healthcare. That is one more technology, which is we simulate, an operation for a person or a junior guy who can really see a 3D picture of it, how it is beating, what all. So, but it was not very successful in academic front when we try to do it because there is active 3D and passive 3D has to be there. And 3D is, what we see in movies. That is the way it doesn't give it that clarity picture because you have to create an environment where it is very much similar and you operate also find out the same thing. But here you cannot on 3D you can see visualize, but you cannot do operations and all. So hands-on would not be there. Then technology and mental health. So this is psychotherapy and all these things are done. And I believe if people can search, there is a Neuralink. Everybody would have seen, heard of this thing. There is a chip which sits in your brain for mental your DNA issue or mental health issue. And through Neuralink, you can reprogram yourself. That is where the DNA issue should be sorted out. This Neuralink came into picture because of Elon Musk. It is making a lot of noise. But in India and Delhi, Gurgaon, there are two researchers they have done. What they have done, they have found out conditions which is healed by, neurologically critical condition, degenerative or conditions can be healed by a certain kind of vibration. That is a music or a vibrator. So the combination of that says, you are getting hypertensive, you are getting, some conditions is coming. In that case, automatically it will induce you to reduce that. Okay. So those are few, fascinating things happening in this world. So remote patient care, monitoring, virtual care is everybody's aware with mobile. You can find out, locate where the patient is, what is the condition, what is the temperature, what is the pressure. So my take is whole is digital twin for health is the topic of today, which I am going to tell you with a small video, which will add your artificial intelligence, your data capturing data points, nanomedicines. This is digital medicine and augmented reality, then technology of not mental health, but this patient monitoring and virtual care all together combined with IoT. I missed out somewhere IoT. So IoT would be there to make it a digital twin of for health. So we can create a digital twin of any manufacturing unit. We can create so many other things, but healthcare it is different because every time, every second you change. And this wearable health things like your watches and other, that is creating, lot of dimension to this. In this case, see what we say, the presence of technology like, artificial intelligence, machine learning, virtual care, and Internet of Medical Things, IOMT. So AIoT, like artificial IoT and industrial IoT, strongly improve medical facility. So this is what is the healthcare ecosystem nowadays with this emerging technology is coming up. So guys, I'll just take few more just to say this artificial intelligence in healthcare, machine learning AI it comes. So I put it a very specific analysis of analyze the CT scans. So CT scan, MRI, and all these things. This space I am also working out. I'll tell you a very classical condition where when you go to MRI and CT, so you have to go through the tunnel of that MRI and do it. So certain kind of conditions where critical condition treatment of effective critical conditions are there. So in this case, critical condition is I'll say you where the AI come into our help is basically uh, basically what has happened. We have got a CT done, but this is an old patient, 80 years old. He is not able to do. So there is an element called dye. There's a blue color print, ink. It is injected in that so that like cardiac uh, cases, when you do analysis for your blockage, this dye is put into that. So wherever the blockage, it is enhanced and you can find it. Similarly, they put a dye in your for CT. So whenever there is a thing, either you use a half dye or a full dye. When the patient is very old, cannot cooperate, is not in a condition who will go through this radiation and all. So in those cases, there is a half dose and full dose. So we have taken 80,000 cases. We are blessed with somebody, good friend, who is a radiologist in Bhubaneswar, gold medalist, who has helped us into this. So, those cases, 80,000 cases, where are healthy cases, they have taken full dose and half dose. From half dose, what is the condition? What is the inferences? For full dose, what is the condition? What is the inference? That has been mapped at a point of time saying what is the accuracy. We got around 86% of accuracy. Half is like this. So full will be showing this is the critical condition it would go. Okay. So a reverse way, we found out whenever there is a very critical patient, old patient, or a patient with very, very critical illness. So we have tried to simulate from if we have given half dose, how does it come? So full dose we cannot give it because they will not bear. So full dose has been given to extrapolate how close the critical disease is. That is where we found out, 68% or something is accurate. At least better than, half dose analysis is this 68% accuracy makes you much more, much more adaptable to take a decision, which is your, you can say, clinical decision. And that is where you update people saying, boss, this is what is we are finding out. What is the condition you want to uh, take? The call of operating, not operating, going through a medication, and all these things are there. Similarly, improving cancer diagnostics. Earlier, you take a MRI, CT, and all these things, it is not going and all. Now it is like, you have digital scans. Huh? So earlier biopsy has to be done, then that comes out of 48 hours. Then you try to take a sample, redo, resample, and all these things. Now, this picture, this digital part of it is like providing the full picture of the organ tissues. Now the digital scan of a particular region that can, cell mutation may impact the key component of contemporary histopathology technique. What histopathology was earlier doing, now with these simulators, these digital scans can constantly be focused. Like you have got a camera looking at you for 2 to 4 hours. Like very commonly people in heart or cardiac condition, they have got a halter in the chest. there is a machine which is tied up to their chest for taking heartbeat, heart rates, where the fluctuation is happening, how long the fluctuation is happening. So similarly, it can really lead into somewhere, constantly that impact. And there is a generic way of finding out those images as well as techniques to, use it to find out this cancer diagnostic thing. So this is a big achievement actually. And then integrate data and analysis. Predictive analysis, I have just told you, what how we analytics part we do for marketing, but clinically these robots collecting data, finding out your EMR. From EMR, he's finding out for the last 6 months what is your vitals, at what time your vitals has gone down, when you woke up, what is your blood rate, your heart rate, what is the reason, because you have eaten what all you have eaten in those days. So if it is a winter, what is the rate? If it is a summer, like these kind of conditions, we always go through and find out. We are like quarks. We know many things. So that is where, this is the replace people with their jobs. Robots, no, but they will augment you to the next level. Such visions are already common in, some fiction movies like Matrix or other places you would have seen robots doing for them. Here they will tell you the pain scale is there from your face. That camera will say the pain scale is 4. So the person who is in and been pricked by, some operation is going on, the others can outside can understand because there is an alert in the facial expression. So that image scanning thing can be identified. Now the pain scale is increasing, so reduce that, or you give the lesser dose, or you just hold it for some time where it gets him settled in the body condition. So this patient pain, we have a pain scale from images, emojis like a kind of thing which we get. And third one is nanomedicines. Nanomedicines, or the use of nanotechnology in healthcare, is medical field, is highly targeted treatments. Like they will put one capsule which is guided wire kind of thing, which we go, like a catheter, or we say endoscopy. So which moves inside that and starts reading that, what is the chemical agent it is there in the body, or takes a fluid camera, takes out the fluid. All these things are coming out without cutting, without inserting some foreign objects and all. Then that challenge medical, that is where these nanomedicines are coming of the age where this is going to be the thing in future. Because these nanoparticles you gulp, you find out, let's say you are getting, one anesthesia. So once given, now local anesthesia has come. Earlier it was a generic anesthesia for whole body they will give. Even if your tooth, you get a full prick. But now the local anesthesia is there. Now it is not in your tummy something is there, then they can give a patch kind of thing which will go and settle down for some time. So all your pain is reduced. So it was beyond our imagination, but it is happening now today. Okay, so how these nanomedicines are there? Tragedy, targeted drug delivery, nanoparticle delivery drugs, particular disease cells, reducing side effects and improving treatment effectiveness. The cancer, it is now going, particularly cancer, you prick the area where the pain is there. There is a gamma machine which radiates and gives. Earlier chemotherapy for whole body, it is impacting. Proton therapy is one more, very costly, but that is where it is cell level, it starts burning it. So that particular cell, particular body is getting, getting treated instead of whole body is getting treated on one time. Sensing and monitoring, this is your, conditions where you need a constant monitoring. Biological markers are there, detect biological marker. I'll tell this continuous fever monitoring is Dozy is an Indian company who gives you a small, like a watch thing, like a digital watch, it will put in your next to your neck or a shoulder on a baby who is getting into constant fever. So each hour it records, each hour it records, each hour it records. Whenever it goes, let's say 104 and other conditions, so it pushes to the system alert. saying, this is where the condition is going. Because certain kind of liver problem people, fever is a critical disease. So you may look, it may look like, just a fever, but it will get them down and then they will collapse. You cannot recover them. So those cases, this dozy in Apollo and other places is creating a lot of Bhubaneswar, this, I believe other hospitals have this thing also. So anytime this monitoring of fever is there, they just put this device on your shoulder or chest and just try to get the information. See, how does it help operationally? There is a nurse running, trying to figure it out, trying to write it down, and then try to enter into the application saying this fever, each 1 hour one is running, trying to figure it out. Not needed at all. That is what is the advantage of this technology. So this device is there. As long as you are carrying in the pocket, they can trace you out. If you are in a bathroom, have you gone walking on the corridor? Have you gone for food or something like that? This is what is each hour it is monitoring, pushing to the system itself. Automatically interface is there, like Wi-Fi. It is getting it. So that is what the key power of health tech. So diagnostics and imaging, I believe this is where these nanoparticles to improve the clarity of MRI scans. So when we give this dye for MRI scan, these nanoparticles, let us understand in a different way. This is, see, different colors are getting enhanced in a different filters. If you get a color filter, so your green is enhanced. So you want to find out, remote sensing. I had worked in remote sensing. Whenever there is a forest or vegetation, you try to give a enhanced filter of green. So all greenery will enhance. So the forest boundary is like this. Similarly, if it is a metal, you give it certain kind of reflectors which is enhanced. So this metal like Kumjar and others, they find out from magnetotherapy, magnetic resonance, they will find out this is the intensity means this is where the iron is there. So similarly, what you do is certain kind of color, this nanoparticles you put it so that this goes enhances that part. You can find out as long as it is given, like dye we use for cardiac cases and CT MRI cases. Similarly, you can do this nanomedicines. Then is augmented virtual reality, face transplantation, and this transplant performed at Cleveland Clinic is one of the cases where you see that virtual augmented users are using augmented virtual reality in healthcare. This technology basically you create a simulated environment and a multidimensional way you can think. Let's say you get this AR, VR, where you can see, you rotate in your hand 360-degree and see that image. Earlier, you cannot. You get a 2D image. Then in a situation here where you try to realize 3D vision of it. So that is what makes this HoloLens glasses where usually surgical planning has been applied in many open heart procedures. So when they see that from the image as well as this patient, it is like when they touch, they know, and 3D wise, this is how it will look like. And the back of it, it will look like this. These are all, we say, PACS is there, one technology where picture archiving is done. So anybody who has got 16 slice, 32 slice, 64 slice, so like a bread, the body is cut into 64 slices. So images are taken. So those 64 slices where each slice consists of maybe 5, 10, 15. So thousands of images are there. Out of that, best 50 or 30 is taken, given to the doctor. But here, if you say AR, VR, they can literally see swinging their hand like a virtual movie, where what all they can be, what is the condition, how it can be. So technology, mental health, I will say digital therapeutics. It is. I'm not going to talk about this. This is only DNA pattern is one thing which I'll talk out of this. See, mental health is a condition where you are shocked, you are petrified, or you are very much. So there is a DNA pattern comes out like every time you're doing exercise, you muscle memory like that. This DNA patterning is there. So people very typically find out fear of something. Okay, fear of the people are doing their hand washing every now and then. They feel something infection is there. Some XYZ reason may be there. Similarly, door closing. And sometimes, you are scared of something. So those are you, it is not a defect in you. You started using so frequently, the pattern has been taking over on your, impact on your DNA. It is a condition you created. So that can be changed. So that is where it is changing, critical cases of pain. So human body is such a thing, if you change that mindset, that point of time, do certain bit of distraction, that pattern can be broken. Once this pattern is broken, you will come out of that condition. There was a doctor who met with a condition, he can lie 6 to 8 months. After that, he started doing this, saying, why don't I get it such a way? My mind will not find that I am under pain. So that is where he got recovered. It was a very classic case, but now he is giving training and all these things. It may come out somewhere into this. The next point is remote patient monitoring and virtual care. So it is all variables where you have a mobile, your GPS is on, your location is on, everything is there. And in these cases, like your IoT devices, sensors are there. So all these things are gadget freak environments where you can find out our patient. We say ICU. There was a condition in HIMSS where we say I see. Look at you like I see you. You. So what we do, somebody has done very significantly, got a HIMSS level award. See this, COVID time, people cannot go touch them, see them, emotional issues are there. ICU, we cannot allow below 15 years people because that is a lot of infection and all. So what they created a EICU kind of a word was there, they put a camera, there is a nurse, there is a doctor, they talk to the patient, the patient talks to the people who is outside of the campus. So legal issue, clinical issue, data breach is a one concern. But if you see other around remote patient monitoring, you sitting in your home, you get to know, the patient is there. So doctor is there in the OT. He can find out what all are happening because he is there in the chamber. He has got a sensor like this meta devices, wearables with specs and all. So you literally see them, what is the condition you can find out. And telemedicine is one where, physically two people are connected through one device, obviously in front of a camera. The doctor is going to see the prescriptions, your physical conditions and do. So that was very, very, nowadays is a very common topic in telemedicine, but telemedicine is doing wonderful for rural healthcare and unreachable part of it. The virtual care includes security, location, service, telehealth, appointment management, secure messaging, all these things are going. See, ultrasound examination on pregnant women and all, we have got a photometer. So anybody who has gone through this, any parent would understand, last moment, every time there is a BP high, there is a sugar high, there is something called a thyroid is getting, up and down, all these things. So you rush to a doctor, you are at a panic mode. But this photometer was there, like you carry one more device at your waist, like a wallet, so which is constantly monitoring at what time, what is the parameter it is coming. And in those days when we started doing it, was a SMS going to the doctor. So, or a clinician who can understand, okay, now this is okay. This is not that panic, but the patient and the patient family used to get panic. What has happened? Everybody cannot attend anyone, very, very, very precisely every time and any time. See, one more smart pill that gives the medical carrier. See, this smart pill is one, like a capsule which was designed. People can find out this. This, according to the Garner, smart pills are ingestible, sensors that may record various physiological measurements. They can also be used to measure the medication's effect and verify that a patient has taken it as directed. That first FDA approval smart pill was released in 2017. People can see this 2017, 2025. So this has been given. So similarly, IoT devices, I'll say, biosimulators, the cricketers, the bowling action, the whole body, which muscles is pulled, which muscles is like they simulate on this thing, IoT development. the sports medicine where this IoT and these smart pills are going to give a lot of dimensions. But this is not a clinically very much established thing, but it is coming up. So digital twin for health. So now I came to the point where, so wearable healthcare, I will not read into this, and this organ care technology and bioprints. See, there is something called, now the devices are coming where you need not prick to take your blood, take a sample on this. See, body human fluids is which is going from your sweat, your smell of sweat. We can find out what kind of chemical variance is there. From there, we can find out what is the diagnosis can be done. So in this case, we say, this working of on a system that, this is where 3D printing, only one was left out. 3D printing has its application in healthcare industry through producing such a things as an external prosthesis. Like, your hand is, you got a hand amputated, leg amputated. Now you see these 3D printings are helping people take a sports career where the leg is amputated. They have IoT devices into this, prosthetics into this. They all together is doing a miracle in this when it is there. So somebody's ear is not there because of accident, it is cut. So they will 3D print according to your color and all. So which can be used as a external result outcome of 3D printing. So that is where these beauticians and these prosthetic people are using it. Overall, this is overall 3D printing at this point of time is coming from somewhere from China. Like we can print your organs, like a heart, like these robotic surgery equipments are looking into that. Sometimes they could save their life by people, fighting cancer because they will try to simulate a cell which is just stronger than, cancerous cell. So if we can generate that kind of a 3D, printing, which is very, very difficult to assimilate now, but that is what is the key element of thinking is going on. Although it might sound unreal, the idea has already entered clinical trials. That means people have started getting that thing done. Organs being tested in clinical settings for 3D bioprinting, including the ears, corners, bone, and skin. So this is where your element of health tech thinking goes beyond certain kind of control or certain kind of thing where you don't think it is there in this world existing. Healthcare data management, I will just say, electromedical records, your wearables, your medical imaging records, your workflow optimization records, your personalized therapies, your personal exercise books, where you have done what all activities are put into one platform or one place, which is telling you, this is what is the key of your whole information about you. That is where we keep all this data put together to create, one digital twin. So here, sustainability, I will come back here, contributes to, decarbonization and contribute to, see, this is where sustainable healthcare is now European Union has decided that there will be no films for CT, MRI, X-ray, ultrasound. So what will be there? The PDF copies will be taken granted and paper copies will be taken for granted. So that is where in my company and our people at Fidelcia is creating PDF images of CT, MRI. Not only reports, we are giving those images medical grade, which is in some other point of time, I will show you. It will go in email, WhatsApp. You can keep it in cloud. You want to access, you want to download whenever it is there. Let's say 5 years, you've done 5 CT MRIs. We'll keep it there. We'll try to analyze 5 years. What is the difference? What is the pattern? Like half dose, full dose, we'll say where you are heading, whether you are getting into, some clog or there is some, muscles issue or you need a stenting to be done in neck because there is, certain kind of blockages. So all these things will come. That is our future. But this is where we are into sustainable healthcare. healthcare data management is done. Then we go to digital, digital twin in health sector. Here, I'll just sum up saying these two are the last one. See, this digital twin is nothing but copying our reality to virtual world, and it is one of the most trendy concepts, often related to the world of digital twin. The big tech organizations and companies are focusing on creating as accurate as possible replicas of the world. If somebody is trying to keep it, the working process, somebody is trying to, we typically try to, try to assess the physical conditions. So technologies like IoT, remotely, we are trying to get the sensor, AI, all data is churned through to find out machine learning is done. So we know the, patterns, we know what is the high and low, virtual reality, 3D wise, how it is to be presented. Sensors are there. So we get to know sensor patches, pain scales and all, 3D printing of ears, nose and all. So this opens up more opportunity for new development among others in the health sector. So what we do, we create a simulated version of you in our world. So whenever you say I've got a pain in my chest, we know what is your height, weight, what color, what weight, what is your vitals, what is your heart rate, what is your blood pressure, what is your cholesterol level. So we can see all the conditions. What is your artery condition? What is the blockage into that? So whether we can say this is because of your muscular spasm, or really there is something to be concerned about your heart internally. So digital twins are dimensionally exact 3D digital models that can be swiftly updated to reflecting changes with their physical counterparts. The growth of this technology made possible by artificial intelligence and machine learning technology. Therefore, the digital twin is popular in engineering applications more nowadays as a mainly manufacturing concept. We are writing about these twins in importance to the industry because we can apply in the health and medical sector. So what we'll do, even if you are there in not in hospital, in your home, we can give you the care what is suppose you will be getting it in your real time hospital environment. Okay. Okay. So okay, I'm going overboard. So I will just do one thing. I'll just show this is the framework, and this is the data capture points like surgery. Da Vinci is been used, dentistry Yomi is used, so implanting it. Then like your dental implant can be can be done. So these are certain kind of approach which is done for digital twin. And if you see how the data is taken care of, this is the thing. We start with IoT sensors, big data analysis, AI machine learning, HM innovations, AVR, 3D and all. So this is where it gives you thinking of what all can be. That MindSphere is one thing which is already into the market by Microsoft, which is creating all these digital twins. So just to say, I will take 1 minute for you people to show a small.
Sir, your audio is not coming. Nikhil sir,
Yeah.
sir, your video audio is not coming. Sound is not coming.
Oh.
Video is coming, but the audio is not coming.
Just check it for a second. Now it is coming. Whether it's coming or not.
Sound is not coming, sir.
Sorry, now it is coming.
No, sir, sound is not coming. Audio is not coming. We can see the video picture is coming, but sound is not coming.
Oh, there may be some way it has to come, I don't know, because my audio is coming. I'm able to hear it to you and to this system. So let is there anybody who can run it from there? Okay, let us see the text how it is going. So the volume part we will take care. Okay, otherwise I'll share it to you people so you can circulate it. Okay, ma'am.
Dear participants, if you have any query, you can write it down in the chat box or you can unmute it and ask to Nikhil sir.
Yes.
Participant, do one thing, write down your query in the chat box.
Yeah. Yeah. I can get Mishra. Any questions from the participant? There is, sir. Could you please? What is this? Is can somebody, sir, please share examples where digital twins or predictive analytics have been successfully implemented in healthcare? Okay. So, Simantika, right? Okay. So this is where healthcare very literally 1-2 places is there, but I can say a very personalized case where it is part of digital twin. I can say is been used. Where they have all detail of the patient has to be there, so which is significantly very challenging thing. Okay, now we can create that partially by getting all detail. See, I'll tell you, one is Dr. Balachandran. I'm taking a name, you can Google it out. Dr. Balachandran was a pioneer in Kellogg School, emeritus professor, Kellogg School. He was the only guy who was from India. He had been blessed with 3 or 4 children who were all doctors sitting in US. So while my interaction, he said, Nikhil, I'm not surviving and my heart is there in USA. So I was just thinking, old man, I've gone for a startup. I'm thinking I'll break the world, jump out of, make, move whole world, turn around with smart ambulance before Corona. So I was on my, high, full high saying, oh, this is what, that is what can do. Then he said, do you know, this is what? Because that heart rate, they had got implanted one kind of a vibrator machine, which is keeping every record of his own world in this. And anytime there is a lag, they need to reschedule. Pacemakers, there is a vibration change has to be done, something has to be done, they will do. If he is getting dizzy or something, it will be identified. So immediately the phone call will come, you take this medication. That is what I have seen partially in my life. This part of time, this I cannot say. This digital twin will ultimately come out as a movie world cyborgs. Whatever the human having all digital gadgets in him working like a robot will be coming up. I'll do one thing. This is a fair bit of question to throw in this community. I will do one thing. I will share this. I'll typically find out and give it. But this is done in other industries are already there. See this, this question is, how can emerging medical technology innovations made more affordable and accessible in the Indian healthcare context? The answer is, Deepika ma'am, is always tough to say a rightful answer. But if you are not in search of money, or you can give it to more of to trial to the public, or you get it done through charity trust, you may get this affordable. Okay, and you use it in the public health domain. You don't make it very much secluded to one hospital or one doctor or doctor's finding. You make it common, then it will be affordable. So anybody has any questions or something, you can ask to uh, uh, can get my mail ID from madam and get it. I want a candid answer in this case. How many have felt it is boring? How many has felt it is interesting but not able to get a big picture idea? Because my content, my intention was basically to just give you the brief of what is healthcare. Then health tech comes into picture. If you don't understand healthcare, where do you apply? You can apply in research, you can apply in diagnostic, you apply in medical technology for operations, you can for medications, you can for operations, day-to-day operations of a hospital, your ambulance, everywhere you can use it. But you need to know where to use it. What is your strength? What is your need of the thing? Okay. Yeah, somebody has shared this video link. You can see that. That is really a good one. Ma'am, I am done for the day. If anybody has any questions, can say anybody wants some kind of a referral, or somebody wants some kind of a thing to do with us, always connect Sumati Baral madam, who will be in turn will interface us. And my mail ID and phone number is there. This is the way. So if anybody wants to communicate me, can call, take a time and talk to us, because most of the time we'll be in the meeting. So that is what is going to create something. Now recently we had designed something which productization is going on. We may try to make intellectual property right, or only other way around we can do anything, we'll do. In that context, anybody has any question, we will share.
Thank you so much for your valuable insights and real world perspectives. Sir, thank you. Thank you once again, sir. Over to Navita ma'am.
Thank you, sir, for this engaging talk. I'm sure you asked whether it's boring or interesting. I'm sure it must have been very interesting for those who want to learn. And thank you so much for shedding light on technology upgradation key focus areas and latest emerging technologies in healthcare. And thank you so much. That's all in session one. And we will proceed to session two. And the topic is AI applications, case studies, and ethical considerations. And our speaker is Dr. Devashree Tripathy, Assistant Professor, School of Electrical and Computer Sciences, IIT Bhubaneswar, Associate, Harvard University. I'll just elaborate a little bit about her. Dr. Devashree Tripathy is an assistant professor in computer science and engineering at the Indian Institute of Technology, Bhubaneswar. Her research spans in computer architecture, machine learning, hardware, software, co-design of AI systems, energy efficient computing, sustainable AI, tiny ML, and systems for healthcare, drones, autonomous cars and robotics, mobiles and edge computing. Her current research focuses on ML for systems and systems for ML. That's interesting. Prior to joining IIT Bhubaneswar, Dr. Tripathy was a postdoctoral fellow in computer science at Harvard University in Harvard Architecture, Circuits, and Compilers Group. She is currently working as an associate with Harvard University. She graduated from University of California, Riverside with PhD in computer science. Such a rich profile. And I hand over the session to Dr. Devashree Tripathy with the topic AI applications, case studies, and ethical considerations. Over to you.
Thank you, madam. Am I audible?
Yes.
Okay, great. I'll share my screen now. Okay, I believe the screen is visible. Thank you so much for the introduction, ma'am. I'll start my session on the AI application and case studies. So I'll skip the introduction part and okay. So as the healthcare is concerned, what is the role of AI or any AI application in the healthcare domain? So, like typically the smart watch that we are wearing, the smart glasses that we are using, like all those things are equipped with certain modules. And the goal of those modules is to extract our healthcare related data and also help us with some semantic understanding, help us with certain tasks such as question answering, knowledge extraction, decision support, summarization, etc. So the healthcare devices that we design are equipped with all these tasks, and typically everyone is using large language models or generative AI models. So one of the important things that these AI models or large language models have to like tune to if they are going to be used in the healthcare applications or in the wearable domain, for example, is so first of all, like these AI models and large language models, they come with lot of computational cost. And second challenge is that they have a lot of memory accesses and memory costs. So what these are, I'll describe briefly in my talk. And for like, let's say I'm asking a question to my large language model, I don't want to wait for 1 hour before it starts giving me the answer. Or let's say if I am asking, I'm preparing for my class, let's say for a lecture, I want the large language model to summarize my slide for me using some visual content. I don't want the visual content to be generated halfway through and the screen crashes, right? Nobody likes that kind of experience. So all these things happen because of the challenges that are listed here, to be specific. And if we want the healthcare domain to make use of the AI models, then one of the most important things that we have to think of is the AI infrastructure part. How do I make sure that my model fits in whatever hardware or computer or system that I have, right? So that is what my research typically tries to answer. So to be specific, for example, in the healthcare domains, one of the primarily used component is the wearables. Wearable example can be wristwatches, smart glasses, the pacemaker, anything can be called as a wearable. And the one of the one defining factor for the wearables is limited battery life, and they have very less processing power. But the challenge is large language model or the AI models that we are going to deploy on those wearable devices have high computational cost, they need high power consumption. So how are we going to make it possible that like the variable with less battery life, with less processing power, still is able to run our AI model and give us the standard output that we are going to expect it to do. It should meet the quality of service. That's a must. But in the current state of art systems, we use large language models, and the large language model needs certain AI infrastructure, but like huge memory processing, huge RAM, high energy, some specialized accelerators like GPUs and TPUs and all of those things. So that's the reason like we need the large language models. In order to deploy that on the TinyML device, we use certain techniques, compression techniques, to make it fit into the my TinyML device. And it should also give me a very good accuracy and without compromising on my quality of service, and also not by not taking too much of energy consumption. So these are some of the defining questions or research questions that the academic community and both the industry as well as academic community are trying to find answers to. The question is, for the healthcare domain, how do I make sure that I'm using the AI models or the large language models, and try to fit it on a resource constrained device, which is essentially what is there inside a variable, and make sure that my solution has reduced energy consumption, takes less latency, and the deployment is also very much cost effective. So this brings me to the like most important topic that is worth discussing in today's session. That is, how do we look at the AI infrastructure, energy efficiency, and scalability? So I have a couple of questions for the audience, and I would appreciate if the audience is as interactive as possible. In the talk, I'll pause at certain intervals, asking for encouraging questions from the audience, and feel free to ask me as many questions as you want. So first question is that what is the meaning of AI infrastructure? Anybody would like to answer it, or are there any thoughts? Do you use any AI infrastructure in your daily lives? Okay, for example, the Chat GPT, which we are going to use, we are giving the questions, and magically using some Vastu or something, it's going to give you some answers, right? So how is it possible that the question that we are giving to it, and like how is it able to process and give us the answer? So what lies underneath? What is it? Is it some magic? Is it some like what is it that makes it possible? So that is the meaning of AI infrastructure. So any cloud infrastructure, your system having CPU or any kind of accelerators, that can also be classified as an AI infrastructure. Any hardware, software infrastructure that supports and enables the AI to deliver the required performance at minimal overhead can be called as an AI infrastructure. Second thing, or second question that we have is, can the scalable AI infrastructure exist without the need of any high performance compute? Now, the thing is, I got to know what is AI infrastructure now. So now what is scalable AI, and why should I care about scalable AI? This question is important in today's world because all the devices or all the wearables, any IoT devices that we are wearing, it's collecting data at a tremendous speed. So all your social media feed, all your health statistics, everything is like is getting clubbed up, and the data set is getting like bigger and bigger and bigger, right? So we need some infrastructure which should be able to handle all this massive amounts of data and make some meaningful insights or give some meaningful insights from it. So it is not possible if my underlying resource, or if my infrastructure is not scalable enough. So scalability here means that like I should be able to handle massive amounts of data, and even if my model size is increasing by 10 times, 20 times, 1000 times, I should still be able to give most accurate results at the minimal time without deviating my my cutoff time. I should be able to deliver good amount of performance. Now, the coming to the third question, um, regarding energy efficiency. So, what is this big deal about energy efficiency, and why am I mentioning energy efficiency in every other slide that I'm projecting? So here, like it's a well-known fact that all the large language models or the AI models that we are using, they consume a lot of, when we are running it for in like extended periods of time, then what will happen is that it is going to consume a lot of energy, and energy is dissipated in terms of heat. So at this rate, if we keep dissipating energy or if we keep dissipating heat, then what will happen is that like it's going to be a very big concern for the climate change and the greenhouse gases. So that is the reason every company today is also looking at the energy efficiency very, very seriously, along with trying to optimize the AI infrastructure, AI models, everything. Like one of the major factors or one of the major verticals that everyone is focusing on is energy efficiency as well. How do I, should I be able to deliver similar performance, the same accurate results with a smaller model or with lesser amount of energy? Is that possible or not? So that is what is one of the most important factors or important components of research nowadays. So now let's discuss, break down the problem and like build our understanding on this step by step. First is like during older days, if someone gives us a problem and says that, okay, can you define what is a cat for me? So in that case, using traditional programming, C, C++, or whatever languages we have learned, we can say that, okay, well, cat, using a switch case statement, we can say that, okay, cat can be defined as like all these features. So the feature means type should be animal, number of legs should be equal to 4, number of ears should be equal to 2, whether it has fur or not, the answer will be yes, and the likes of the cat are yarn, catnip, etc. So then fast forward to 2012 with the wave of neural networks. So if I go for a supervised learning approach, what I'm going to do is I'm going to give my model a set of different images. Some of them should be cat images and some of them should be some other object or other animal images. And then once my model is trained properly, then when I ask the model the same question, like I'll give the picture of a cat in another posture, sleeping posture, for example, in that case, the model should be able to correctly guess that this is the picture of a cat. Now, again, trying to answer the same question with the emergence of the generative language models. Like some of the examples of generative language models could be Lambda, PALM, GPT, etc., etc. So here we do not use any supervised learning approach, meaning we don't use any label data. Here we basically tell the model, okay, here go to the library and read all the huge pile of books which has information regarding cat as well as million other concepts. So once the model is trained with the concepts of the cat as well as other topics or other concepts, then when I ask my trained model this question, what is a cat, it is going to tell me the output, like depending on whatever it has learned or it has whatever it has been trained on, using this huge pile of books. So it is going to say that a cat is a animal with 4 legs, fur, etc., etc., whatever it has learned from the books. So if I now define what is a language model, then we can think of a language model as some, let's say we can take for the time being, think of it as a black box. The input is to the model is a prompt or a question, typically in question answering task. And the output that we expect out of the model is a text-based response. And the processing that happens in the middle is basically the large language model is going to analyze the input and then generate the response based on the patterns that it has learned over the time. So the large language model, we can define it as a subfield of deep learning area, and like it should be capable of accepting this input, giving this output, and it should be able to process the input and generate the required response. Now, going to the next, let's try to understand this using some large language model use case. And the use case that we are going to study today is like predicting the next word in the sequence. So let's say that my half sentence or partial sentence is last night I was reading Harry Potter and then there is a fill in the blanks type of question. We have to predict what is the next word that is going to occur in my sequence. So typically what will be the answer that like a human being, if this question is being asked to a human being, what is the answer that the human being is going to give in this kind of situation? Anybody from the audience would like to answer? I'll pause for 2 minutes so that we can collect some answers and then we'll proceed.
Dear participants, you can write the answer in the chat box itself.
Okay, let me do the icebreaker and answer this myself from the next question onwards. Maybe we'll wait for a little longer so that everyone is able to participate. So, Harry Potter, if you ask me, then I recollect Harry Potter being a central character of in a book, and then also there are certain movies that have been built around that central character. Basically, the book movies made out of the book have been based off of Harry Potter. So I know that Harry Potter is a fictional character. So when the question is last night I was reading Harry Potter and the fill in the blanks, then maybe they're referring to Harry Potter, some of the books written with the Harry Potter. So then what I'll do, I'll search for the books that are written with Harry Potter, that exist with Harry Potter keyword in their names. So Harry Potter and the Sorcerer's Stone, Harry Potter and the Chamber of Secrets, etc., etc. So yeah, as you can see, the names of the books put on the right side, they have a certain pattern. They have in the name itself, we have Harry Potter and the something, right? So so by looking at the names of the book, the series of the books, I can easily guess that okay, maybe like the next word in the sequence is name of one of the books. So the next word can be Sorcerer's Stone, next word can be Chamber of Secrets, next word can be Goblet of Fire, and so on. So, and based on the frequency of occurrence of in my data set, my training data set, how frequently the next word occurs after Harry Potter and the phrase, based on that, like the probability is being calculated by the large language model. So, here the probability has been mentioned and we have basically arranged it in the descending order. The highest probability has been listed on the top. So going by this example, what my model is going to do, my model is going to just pick the first value after sorting it in the order of probability and just fit it in. So, because philosopher has the highest probability of occurrence after the word Harry Potter and it's going to fill in philosophers in this sentence. So now the question is, okay, I got my answer to the previous question. Now what I will do is I am going to twist my question a little bit by adding some context. So the context that I have added or I'm planning to add is this. Remember, I live in New York and I bought my book from the United States. So how does it change my answer to this question? So it changes because the first Harry Potter book was actually published as Harry Potter and the Philosopher's Stone in most of the countries. But the publishing house thought that the US audience do not know the meaning of the word philosopher. It was not a commonly used word in the United States. And that's the reason they basically renamed the book and launched the book as Harry Potter and the Sorcerer's Stone in the United States. So the fact that when I'm saying I live in New York and I bought my book from United States, that basically changes everything. It basically uh, tells me that the probability of me reading Harry Potter and the Philosophers is less and Harry Potter and the Sorcerers is more. So by doing this, I'm going to specifically zoom into the data that have been collected from the New York or US audience, and basically out of that, then I'll recalculate my probability with new added context. And then this model is going to return me the answer as Sorcerer's Stone. So then I'll fit it in the next, the fill in the blanks basically. So I have learned what is a language model so far. Now, what is large about it? Why do we call it a large language model? What is large about it? That is the question we are trying to find an answer to at this point. So the word large basically comes from the fact that it has been trained with massive amounts of data, text data to be specific, to understand and generate human-like text. And it also has certain key characteristics like massive scale. So it is trained with billions of words. The model size is also huge. It is built up of the deep learning architecture, which utilizes again neural networks, and it also uses unsupervised learning, with which means that I am learning from the raw text data without the need for explicit labeling. So in the large language model examples, there are some commonly used large language models like Lambda, like GPT-3. GPT stands for Generative Pre-trained Transformer, which was developed by OpenAI company. And there are also some other big companies like Google who have come up with numerous different models. Some of them are basically Lambda, which refers to language model for dialogue applications, and BERT. BERT basically stands for bidirectional encoder representations from transformers, and so on. So, okay, this figure basically zooms into the experimental setup that I have in my research group. So we have learned about large language models so far. So large language model maybe or the workload, so that it needs a training framework that I'm going to use to deploy it on my hardware or my CPU GPU server. So this one, the figure shows that I have two computing nodes. Each computing node has a CPU, and both the nodes, the gray boxes, are connected to each other using network interface card, NIC. And then each CPU is connected to a cluster of GPUs. So, and this cluster of GPUs are going to communicate with each other efficiently. And why is there a need to keep a cluster of GPUs? Because remember, I have large language models. I have huge amount of training data, huge amount of my model size itself is also huge. So my single GPU memory cannot fit in the whole model. So that's why I'm going to partition the data and put it into different GPU memories, and in the hope that this will be able to give me the best performance. And second thing is that, like, because I have partitioned my data, there is still some overlap between the data that this GPU is processing and this GPU is processing. So they have to talk to each other through communication channel in order to process my data more effectively. So this is the entire setup that helps us process the large language model applications. So first is like we have the large language model workload, which is it sits on top of the training framework. Then we have this communication, this arrow marks basically tell us that there is communication going on. So we have some collective communication framework, and the GPU for programming the GPU, or for the GPU to interact with me, I need some GPU driver. And then on the on the bottom, we have the CPU GPU server. One of the important things here to note is that GPUs cannot perform isolatedly. They have to be connected to a CPU, because GPU are slave devices. They cannot operate without having a CPU in the system. So the CPU is the master here. It divides the workload, divides the model, and among the GPUs, and says that, okay, GPU 1, you are going to operate on data X, GPU 2, you are going to operate on data Y, and so on. And this slide basically is not to overwhelm you, I promise. So this slide basically tells us the need for high performance computing. So starting from the banking sector, let's say we'll start with an example. COVID-19, the pandemic hit us really hard. Let's assume that I have a startup business and I made lot of losses because of the pandemic. There was loss of revenue, and because of the loss of revenue, I still want to become successful one day, and I still want to borrow some money from the bank, and so that I can buy myself more time to be able to make some profits. So what will bank do? Will bank give money to whoever asks for it? No, right? So they have some decision making algorithm, they have some decision making process. So for making all this decision, they are going to look at all the data, that your personal data, professional data, shared, unshared, with or without your consent. They're going to have access to all that data. There are some companies who have all your data with or without your knowledge. And all that data will be processed by the bank. If I'm someone who likes to spend money randomly without proper plans, if I'm someone who spends a lot of time at the casino, then bank will stay away from me. They'll try not to give me any kind of loan. So all this personal data and everything, bank is going to process, and based on that, it's going to give us a decision, right? So similarly, all the healthcare data, everything, some infrastructure or some HPC platform needs to process those huge amount of data in order to derive some meaningful insights out of it. So now the question is, what is a cloud? And my options are: is it a cluster? Is it a supercomputer? Is it some data storage device? Is it a superman? Or none of the above, or all of the above? So which one would you pick? Number three, it's a data storage device. So clouds, do they not do any kind of computation? They just store the data.
Yes, spelling.
So actually, it's yes, it does do data store. It also does computation. Cloud also have computing clusters, right? So we can the answer here will be all of the above. So cloud, we can define it as something which has lots and lots of storage, and it also has compute cycles nearby. So what does compute cycles nearby mean? So let's say I am in my office and I have back-to-back meetings. There is some 15 minutes break between two meetings and I'm really hungry. So will it be more effective for me to basically arrange my lunch there ahead of time, heat it up and eat it in my office? Or will it be a better solution if I come all the way to my home in Bhubaneswar, eat my lunch and go? So which one will ensure that I do not miss any timeline of any of the meetings? And also I have my lunch on time. So which solution would you prefer? Eating food in my office in that short 15 minutes break, or just forget everything, come to home all the way from to Bhubaneswar, which takes 30 minutes commute one way, and then eat my lunch and then go back? First one. So first one meaning like I'll eat my lunch in my office, right? So here in this example that I discussed, so if I come all the way, if we go to the previous example here, if I come, let's say my data is in the GPU, but I come all the way from this CPU to GPU and then compute my data in here and then go back again. So you can think of how many hops I have to take. I have to take this hop, this hop, and then like I'll be reaching this CPU, right? So that counts as all the commute time, the 30 minutes commute time that I was talking about in my example, in my option two. That is what the commute time. So we have to make sure the compute cycles. So if my data is in GPU2, then I should be able to compute my task in the GPU2 itself. So if my computation cycle are increased, then it will lead to bad performance. So if the performance is bad, I'm going to miss my next scheduled meeting. Then in this case, here I am going to delay the output uh, for a longer time, which is no longer acceptable to the user. So yeah, basically the question now is, does cloud use high performance computing? Yes, the cloud or like any data center that we use consist of compute nodes, millions of them, and then switches that are going to connect to compute nodes, network topology, and second thing is that like it may be geographically present, all the nodes can be present at the same site, they can also be present at the different site. So the question now is like the chat GPT, let's say that you're going to that you're using, or Gemini or Microsoft Copilot that you are all using, does it use cloud computing in any way or no? I think the session has been going on since 3.5 hours, and the audience are really, really tired by the end of their day. Okay, so the answer is yes for my question, like for my guess that you're all are tired, or the answer is yes for the question that I asked, that whether the chat GPT that you use has cloud infrastructure underneath. Okay, so I'll guess that for chat GPT question. Okay. So yes, like the all the AI infrastructure, sorry, all the generative AI tools that we use on our day-to-day basis, that basically runs on the cloud. And when I'm asking a question, the computation is done on the cloud itself, and then it gives me the answer as soon as possible. So, to summarize whatever we discussed so far, there are three driving forces of computing. One is what it is, we can think of it like a magic box for the time being. So, one thing is like I need faster computation. I cannot wait forever to get my answer, and I should make use of better algorithms, parallel algorithms, and like the big O notations. It should be time efficient, it should be space efficient, all of those. And I need also a lot of data, because the more the data, the more accurate will be my model. My model is not going to underfit or overfit. So after that, at the end of the day, I will need better value for money. So like this whole thing is a single package. And the green part is the magic box that makes it a possibility or makes it feasible for us to imagine the magic box which can take in like more data, promise like better algorithms, and like do faster computation, and in the end it will give me better value for my money. So, to summarize the challenges and limitations so far, from the eyes of a computer architect, the challenges of the large language model uh, during optimization include: one is the memory constraints and memory management. So, memory constraint, as in, I cannot have unlimited data storage device. That is not possible. One is like even if I have a very big memory, then like I'll need a lot of time to retrieve data from my huge memory, right? So let's think of an example. Let's say we are reading a book before the exam, and I have a small bookshelf which contains only 5 books. So will it take me more time to like find a book from the set of 5 books, or like will it take me more time if I go to a friend's house which has 500 books in the bookshelf, and then I'll have to search through all the books to find the book that I need? So in this two example, the one with 5 books will be more faster and more efficient, and whereas the bookshelf with 500 books will be comparatively slower to find a book from there. So again, like even if I get a huge size of memory, then searching something from the memory is a time-taking task. And how am I going to manage the memory is another question that I have to answer. The second point here is basically have we need huge computational complexity, because I have lots and lots of data. So and very like very efficient algorithms have been there, and I need faster processing. So all these basically zeroes down to more resource requirement. When I say resource can be more computing cores, resource can be more memory size, resource can be more number of accelerators, it can be anything. And at the last, I also need to think about my latency as well as throughput. Now, what is latency and what is throughput? I'll let the audience take some time to think. We'll pause for a 5 minutes break, and then I'll will basically resume the session. So yeah, like, and after the I we resume the session, I would like the answer from the audience that what is latency, what is throughput, or do they mean the same thing, or they are different? Okay. So no response in the chat box. All right. So okay. Latency is the delay, and throughput is the amount of data processed at a given time. Right. So latency is data transfer with respect to time, and data amount of data transferred with respect to volume. Very good. Yeah. So latency is basically with respect to time. Like when I start my task and the finish time of my task, finish time minus start time, that's the latency. And at per unit of time, how much data I'm processing, that's basically my throughput. Now the question is, if I think about which one is more important for me from the AI model or the large language model context, then what would be the answer? Like, is latency more important for me, or is throughput more important for me, or both? We should care about both, because latency is, yes, like each individual task should be completed as soon as possible, and we should also think about how at a given unit of time how much data I am able to process. Okay, so now coming to another interesting experiment that Google Brain did. So anyone recognizes the person in the picture on the top right corner of the slide? The name of the person already is mentioned in the slide. He is Andrew Ng, a Stanford computer scientist, and he has lots of video lectures on YouTube teaching ML to everybody. So yeah, so when he was associated with Google Brain, he basically did an interesting experiment where the task was to recognize the cat and people images on internet, and the data set that was given to them was about 10 million digital images found from the YouTube videos. And the method that was used was unsupervised learning. So in 2010, they did this experiment, and like the number of compute resource, which was CPU back then, they needed was about 2000 CPUs, and each CPU node had basically 4 cores. So this translates to about 8,000 CPU cores in 2010. So in 2012, when GPU came to the mainstream, like with the help of the software library like CUDNN, which stands for CUDA Deep Neural Network Library, it's basically it simplified the implementation of deep learning algorithms on the GPUs. Um, this number, 2000 CPUs, like reduced to 48 number of GPUs. So, which is a more scalable solution in your opinion? So, keeping a rack, huge rack to house 2000 CPUs, or keeping a rack which will house about 48 GPUs? Which is a more scalable solution? The lower is better in this case, right? So, in this case, I'll prefer like having GPUs which do the same amount of data processing with lesser number. Again, reinforcing on the similar takeaway, this is a slide taken from the GTC 2015 talk, again by Andrew Ng. So here he basically reinforces the fact that the deep learning is driven by the scale. So in CPUs, we had 1 million connections, and then like it scaled up to we had GPUs having, which was capable of handling 10 million connections each. And then we moved on to clouds, which had many, many CPUs. Now it's now capable of handling 1 billion connections. Remember, this is a GTC 2015 talk slide. So as we are talking, this number has increased or expanded by great amount. And in the HPC, which has many GPUs, we have about 100 million connections. So to summarize all the discussion we had so far, we have huge amount of data. Plus, we like in the AI with AI, it needs a HPC cluster or high performance computing system for complex workloads and data intensive computing. So yeah, the problem is we have data and compute requirement of large language models and AI models, which is huge. And the solution that is offered is we have advancements in the hardware, algorithm, data sets, etc. And okay, so anyone recognizes the person in this picture now? So, in the computer architecture, both UG and PG classes, we have a famous book like all over the world. The book is called Hennessy Patterson. So in the UG also we study Hennessy Patterson, computer organization and design, and in the PG level course we teach computer architecture, a quantitative analysis. That's again authored by Hennessy and Patterson. And in 2017 they won Turing Award, so which is one of the highest award in the field of engineering. So both of them got awarded for their contributions to the computer architecture community, or like the whole systems community to be specific. So this is, I was like, I met them in person and I was attending that conference. And this slide is taken from their video lecture. All right. So the main takeaway from the slide that they were trying to portray was like on the x-axis we have the number of years. On the primary y-axis we have the technology scaling. So what does technology scaling essentially mean? What will we gain if we reduce this nanometer? All I can understand from this figure is the orange line is going down, and the which means that the nanometers is going down. So what will, like, how is it going to help if the nanometer reduces? So if my nanometer reduces, all it means that my basic computing block, the size of my basic computing block is reducing without affecting the capacity of that specific block. So which means that I can fit in more and more amounts of transistors, which are the basic building blocks of my computing. And if I can fit in more and more number of transistors, which means that like in the same chip area, I can have more number of transistors as in the same chip size will be able to deliver high amount of performance. So if you remember back like 20 years back or 30 years back, what was the size of the mobile phones? And now what is the size of the mobile phone that we are using? So laptop, palm top, that was all a dream back then, like 30 years back, did not exist. And if you compare the 30 years back laptop or desktop with today's desktop, like that one was way, way slower, right? So that is all because of the nanometer scale, like the technology scaling. We are able to fit in more computing power in a small chip. So that is what the orange line was saying, conveys. It's a good thing. But the trade-off or the challenge that comes with that is the blue line, which means that my power density is increasing, means the power per nanometer square is increasing at a massive rate. So here, like the this slide basically talks about the 40 years of processor performance. So initially we had RISC, that was, sorry, earlier we had CISC, which was complex instruction set computer. Our x86 are all CISC architecture computers. And the reason why John Hennessy from Stanford University and David Peterson from University of Berkeley, they got Turing Award was because of the green part. this was their main contribution, which got them the Turing Award. So their contribution was reduced instruction set computer, where they said that no need to process complex instruction, break it down into small parts, and we can like go with simpler instructions instead of the complex ones. So the ARM chip, for example, the Apple processor, all the Apple processors are ARM chip, which is based off of RISC. The main contribution of RISC was like make the processor simpler, make the instructions simpler, and the energy efficiency of these processors were way better than the CISC. And that's the reason Apple sticks to the RISC architecture still. Then after 2004, what happened was that the frequency of the single core processors did not increase. So if the frequency did not increase, the performance has hit a bottleneck. So what they did, they, instead of pushing or forcing the single processor to process as much data as possible, they broke down the data into small chunks and started making like having multi-processors basically. So with the end of Dennard scaling and they started using multi-core processors, and which again helped grow the performance by almost 2x per 3.5 years. And then also, like when I say, okay, your performance is not good enough, now increase the number of processors. If you increase the number of processor, the overall performance is going to increase. But there has to be some theoretical limit, right? So if I basically I get 1,000 more processors and divide my task between 1,000 processors, does it mean that my performance is going to increase by 1,000x? Is that a reasonable assumption to make? Yes or no? The question is, I have a task and I am going to bring in 1,000 parallel processors and divide the task among the 1,000 parallel processors. So if I divide the task among the 1,000 parallel processors, will my processor performance increase by 1,000 times or 1,000x? Is that a reasonable assumption to make? Actually, no. So that is what no, ma'am. Actually, it's not possible. If I have 1,000 number of parallel cores, I cannot increase my performance by 1,000x. And that is what Amdahl's law basically defined. Why? Because not all tasks are 100% parallelizable. Let's say I am making some dishes, let's say biryani, and my gas burner, I have only single burner stove, and the stove is already at the highest flame. That is basically my frequency bottleneck, right? So what I do is I'll borrow I'll knock every neighbor's door and I am going to borrow their gas stove, saying that, okay, can you give it me for 2 hours or 3 hours? I'll make biryani and I'll return it to you. So in that case, like the 1,000 stoves that I have borrowed from my neighbors, in this analogy, they are similar to the 1,000 processor performance. Will I make, if the usual biryani cooking time is 2 hours, will I be able to cook the food between by 2 divided by 1,000 hours in that time? No, it's not possible, right? Because when I'm making biryani, there are a lot of sequential steps that I cannot pass through. So the sequential steps, meaning cutting the vegetables and soaking the rice, all the pre-processing steps, that there is no way I can parallelize even if I have 1,000 extra stoves. Only the cooking time that like of the boiling the rice and stuff, like yes, that can be parallelized. So because of all these constraints, it's not possible for me to achieve 1,000x speed up if I am having 1,000 number of parallel processors. So that was around 2015, and then comes the red part. So is it? Is that it? Like, is there? Does this mean that the processor industry is dying? There is no more performance benefit that I can get. So they answered this question in their talk itself by focusing or by pointing us to look at the domain specific. So here the goal was they achieve higher efficiency by tailoring the architecture to the characteristics of the domain. So instead of looking at just one application, here I have a set of application which I call as domain. And with the domain specific knowledge, I'll tune the general purpose processor to become a special purpose or a domain specific architecture. So some examples of domain specific architecture. For machine learning, GPUs for graphic processing units and virtual reality applications, and different programmable network switches and interfaces. Okay, so now that like CPUs cannot keep up with the growing need for the GPU computation demand, we need accelerators for better computational power. And some examples of the accelerators are this GPU, graphic processing unit, FPGAs, field programmable gate arrays, and ASICs. ASIC is basically application specific integrated circuit. So a comparison between all of them will be more general purpose, but very less efficient when compared to GPU and FPGA and ASIC. So but in terms of energy and efficiency, like efficiency meaning performance, cost per unit is basically energy efficiency. So in terms of that, ASIC are basically the best. And when we say SoC, same chip, then we call it a system on chip or SoC. And during my PhD, I was looking extensively at the GPU aspects, GPU energy efficiency, scalability, etc. And during my PhD at Harvard University, during my postdoc at Harvard University, I started looking at the whole system holistically. Yeah, I think throughput and latency we already discussed. Just for the sake of discussion, like if I'm starting from my home to work and there are two solutions to it, car which takes 30 minutes, bus which takes 45 minutes. Car has 2 seats and bus has 100 seats. So in this case, the latency of car is 30, latency of bus is 45. And the throughput that is basically the number of passengers that I'm carrying at a given unit of time. Throughput of the car is 2 and the throughput of the bus is 100. And in this example, the bus basically is the GPU and the car is basically the CPU. I wanted also to give a brief idea about what GPUs are and how they are different fundamentally than the CPUs. So actually CPU and GPU are designed very differently, and the purpose of this slide is to show pictorially so that we can develop some mental model of what their differences are. So first point of difference is the cache memory. So as you can see, the yellow portion is much bigger in the CPU compared to the GPU. Second thing is the GPUs have resistors. The red portion, the resistors are bigger in the GPUs compared to the CPUs, and the SIMD units, which are basically the computing cores, they are also very big in the GPUs compared to the CPUs. CPUs have control logic, but GPUs do not have any control logic. Rather, they have a thread management logic. Let's try to understand what is the purpose of each of them. Right. So first feature in the CPUs. Okay. So some of the feature, like all the features in the CPUs, basically help it to become a latency oriented device. So what does it mean? So first feature is like it has some powerful ALUs shown in the green color. So the powerful ALUs help to reduce the latency of a given arithmetic logic operation. Second is they have very big caches because the caches can convert the long latency memory accesses to short latency cache accesses. And the third part is the control. They have a very sophisticated control mechanism and which are equipped with some good branch prediction and data forwarding techniques. And the GPUs, on the other hand, they have smaller caches which help boost the memory throughput. And they have simple control, no need of fancy control. They don't have branch prediction, they don't have data forwarding. And second thing is they have very efficient ALUs, which makes use of many long latency but heavily pipelined cores for high throughput. And then last is so there are lots of parallel threads that are running and using all these cores. So there has to be some management mechanism for managing all those parallel cores. So that is why we have this uh, basically in the previous figure, we had this um, thread management logic, which helped to manage the thread logic and the thread states. Okay, to summarize, we have CPUs which are better with latency-oriented design, where latency matters for the sequential parts. The CPUs can be way faster than the GPUs if I have sequential code. But now, if I have lot of parallel code, then in that case, GPU will be a better design choice to make because in that case, I can make my code almost 10x faster. So yeah, one of the thing is high performance computing is achieved by caching. Again, like we discussed this through the session. So I'll skip this as of now. And yeah, basically the GPUs have multiple layers of caches, just like the CPUs. Um, and the smaller and the faster cache is close to the GPU, and the larger cache is away from the GPU. And when we are designing a heterogeneous parallel computing system, we use the best match for the job. For example, we will have different varieties of processors in the SoC. For example, mobile SoC will have latency cores. For example, CPUs will have throughput cores. In this case, GPUs will have different hardware IPs, DSP cores, configurable logic cores, and on-chip memories, etc., etc. So this is best suited for AI or AR/VR applications. Another thing that helps achieve high performance computing is parallelism versus concurrency. So parallelism I can have if I have multiple resources. In this case, Coke vending machine is the resource. If I have more number of Coke vending machine, then I can serve two queues in parallel. No problem with that. But if I have just one Coke vending machine, I still want to serve two queues. What I will do is I'll say, okay, you think about the order that you're going to place. And by that time, I'll finish the transaction with the person who is standing at the head of this queue and vice versa. So yeah, I think we can skip the details of the Amdahl's law. And yeah, basically GPU in GPU, like we have a CPU, which is again the master device, and it breaks down my application into smaller kernels. And then there is some unit called as thread block scheduler, or because this yellow boxes are called thread blocks. And then these boxes here where SM is written stands for different multiprocessors. So we have thousands of multiprocessors within the GPU, and the thread block scheduler is going to take one of the thread blocks from the kernel and map it to different SMs. So I'll try to pause here and then see if anyone has any questions before proceeding. No. Okay, so next the thing is why we need to optimize the LLM inference on the GPUs because of the high speed that the GPU offer. They can process large amount of data in parallel and thereby significantly accelerating the LLM inference. And second thing is the efficiency. So the optimized inference here can reduce the computational cost and the energy consumption. And the third thing is the scalability. So the GPUs can be scaled to handle larger models and the workloads like we saw in the Google Brain example. And second thing is before I end the session, I would like to shed some light on how has the deep learning hardware evolved over the years. So here on the x-axis, I have time, and on the y-axis, we have the complexity of every model. So like it stands for petaflops, which is a measure of the throughput, and multiplied by days of training. So the complexity of the deep learning model has actually increased dramatically over the time. And for example, only from ResNet to BERT in 2 years, or from BERT to GPT-3, BERT came in 2018, GPT-3 came in 2020. It has increased by almost 1,000 times. So the ability to successively train the complex models is now heavily dependent on increasing the hardware performance. Again, this figure shows that like how the single GPU performance has scaled up over the years to meet the demands of the deep learning. So the GPU inference performance here we can see that like on the y-axis it's again throughput integer 8 tera operations per second. The graph on this basically shows the different generations of GPUs, the model number, and the green one shows the absolute number of the throughput that we are or inference performance that we look at. So here the GPU inference performance has increased by about 317x, which is more than doubling if we take an example of 2012 to 2020. So Kepler to Ampere, like it has increased by more than 2x per year. And this is now called as Wong's law. And that became possible because of various different factors, such as we had different data types like int8 data types. Remember the figure that I showed, which had about 8 GPUs in my lab system. So each GPUs need to talk to each other through a very efficient channel. So some work has been done from 2015 to 2016. NVIDIA introduced something called as NVLink, which enabled faster GPU-GPU communication. Then again, clusters of GPU, they connect to each other using the NV switch. And then we had support for the different data types in 8 cores. And then we had tensor core support for sparse data computation. So many of the AI models, they have sparse data. So for handling that, we need the tensor core support. So yeah, I'll basically end my talk here that like there are lots of hardware as advancements for accelerating deep learning models on the GPUs. And there are also software advancements that have aided this progress. And the reason why the efficiency or the energy efficiency matters a lot is again the same GPUs taken on the x-axis. If we see the green, the blue part is good, like the performance has increased over the years. But the problem is the orange line here. The power consumption of those different generation of the GPUs has also increased significantly. So yeah, basically, like there is with the increase in the high performance demand, there is also significant increase in the power consumption, and this is because of technology scaling, increasing number of cores, and other microarchitectural changes. So yeah, basically that's a very like important challenge that the present day GPUs suffer from, both energy and performance challenges. So yeah, for developing the AI models, we also have to take the scalability, the AI infrastructure challenges, energy efficiency really, really seriously. Yeah, I think I have reached the end of my session.
Can you hear me? Devashree ma'am? Ma'am, are you there? Madam, can you hear me? Ma'am, can you hear me?
Yes. Hello.
Ma'am, can you hear
Yeah,
me?
yeah. Yes, yes, yes. I am able to hear you.
Yes, ma'am.
So yeah, one of the ethical risks for AI generated content in ChatGPT, like ChatGPT in academia, I think one of the audience asked this question. So one of the challenges that I face is I teach computer architecture. My background is computer architecture, and ChatGPT is not trained with lot of computer architecture data, right? So whatever answer it gives is very, very wrong and absurd answers. And second thing is the copyright infringement does not when you are having AI generated text, you don't know whose data it has taken inspiration from, right? So that's one of the major challenges. And I think the AI tools, because people have started using AI tools a lot, many papers in the journal and conferences are getting retracted because of taking generous aid from AI without putting the original contributions in the paper or in the work.
Thank you so much, ma'am. We are very much delighted to have you with us. And actually, it is very insightful session. You have explained the GPU and CPU in a clear-cut manner that will be very effective for the research scholar. Thank you so much, ma'am.
Thank you, ma'am, for having me.
Thank you, ma'am. Okay, ma'am. Dear participant, do you have any query to Devashree, ma'am? You can put it in the chat box. Madam, I think there is no query related to GPU and CPU. So, ma'am, thank you so much, ma'am.
By this, we conclude our session. So next tomorrow, our first session timing is from 6 to 7:30, and next session time is from 7:30 to 9. Okay, thank you everyone.